Yeah, we are live.
Well, good morning, everyone. On behalf of the Bombay Orthopaedic Society, I am very, very happy to welcome all of you to the first program of this year, and which is the BOS Master Series on Pediatric Orthopedics. We are going to showcase practice-changing ideas. Very few subjects have actually witnessed as much a change in actual practice as has been in pediatric orthopedics. There has literally been a turnaround. Saral, may I request you to mute yourself? Admin, can you mute him?
Hello.
Are all other participants muted?
Hello.
Yeah, all are muted.
No, now we are muted.
Yeah.
Sorry again for the technical glitch, and we are back on. What is life without a little excitement? So it's nice to have a good wake-up start to everyone. So like I was saying, pediatric orthopedics is the subject which has witnessed the maximum revolutionary changes actually in day-to-day practice, in surgical practices, and in terms of approach to the patient. So we have a lovely girl-powered convener team today, that is Dr. Chasnal Rathod and Dr. Ratna Maheshwari, who've crafted out the best 4 major areas in which there has been a sort of a renaissance or a complete turnaround in the way children are being treated now. So without much ado, I hand over the proceedings to Dr. Chasnal and Dr. Ratna to conduct the 2 sessions. They will tell us about what areas are being showcased and the speakers and quick introductions, and we start with the PPTs soon. Chasnal, you're on mute.
So very good morning to everyone, and thank you for joining us on this Sunday morning. And we are very glad to have this master series in the beginning of 2022. And as the new theme or the new normal, or we talk about new ways in the new year, we are here to talk about practice changing trends in pediatric orthopedics. What has changed over the past years and how practice has developed or evolved over this time. And I would like to introduce my co-convener, Dr. Ratna Maheshwari. She's with us. And to begin with, we will start with the first session. And so we have the first speaker from the opening speaker from the first speaker, Dr. Mandar Agashe. And we have the session on hip preservation and how things have evolved in this session, how things have evolved in terms of DDH, SCFE, femoral acetabular impingement, and adolescent hip preservation. So we have Dr. Mandar Agashe, Dr. Sandeep Vaidya, and Dr. Prasad sir, all the way from Chicago. And we thank all of you to make this session a wonderful thing. And over to you, Mandar, with your talk. Please share your screen.
Chasnal, I'll be just convening the talk. The first talk will be given by Dr. Sandeep Vaidya, who will be talking on early and walking age DDH.
Yeah.
Over to you, Sandeep.
Okay, so let me just share my slides. And thank you, Chasnal, Ratna, and Ruchita madam. So very interesting topic this, changing practice changing ideas in DDH. And this topic just encouraged me to think back as to what really has changed in the management of DDH over the past 2 decades that I have been seeing and managing DDH since I joined as a senior registrar in Wadia in 2014. Frankly, if you look at it, treatment of individual cases, not much has changed. I mean, if you look at the management of DDH diagnosed in early infancy, less than 4 to 6 months age, Paulic harness is the treatment of choice, and it has been around for at least 7 to 8 decades now. If you look at the slightly older child, that is up to about, say, 1.5 year age, the treatment of choice still remains close reduction, arthrogram and spica, and it has been around for more than a century now. And also, if you look at the walking age DDH, the surgical techniques that are carried out today, that is open reduction, pelvic osteotomy, femoral osteotomy, these again have been around for several decades now. So superficially, if you look at it, not much has changed. And yet, there have been some exciting practice-changing ideas that have come about in the last, say, 5 to 10 years, which promise to change the outlook of DDH at a community level. And here I'm going to touch upon 3 points. The first point is primary prevention, which can be achieved by increasing awareness about postnatal posturing. The second point I'm going to talk about is early diagnosis. And here I'm going to talk about efforts to develop a screening program which is specific and tailor-made for the Indian scenario. And third, I'm going to talk about the effort to solve long-standing controversies in DDH by developing global collaborations through the International Hip Dysplasia Registry. So the first point that I'm going to touch upon is prevention, and here I'm going to be discussing the role of postnatal positioning. Now, if you look at the risk factors of DDH, the risk factors for DDH, namely the firstborn, female child, breech presentation, intrauterine overcrowding, positive family history, these are risk factors which have been known for a long period of time. Additionally, the last mentioned risk factor, that is postnatal positioning, it is of special interest to us. And why is it of special interest? Because it is a modifiable risk factor, meaning that it is a risk factor which can be modified with simple intervention. So let's discuss this a bit more detail. So postnatal positioning, restrictive immobilization implies positioning where the infant's hips are tied up in forced adduction and extension and knees in extension. And this is the position which is still adopted in most of the Indian households where there is a tradition to swaddle the baby in restrictive swaddling. It has been shown, and there are multiple literature articles to prove that such type of restrictive immobilization is detrimental for hip development and predisposed to the development of developmental dysplasia of hip. On the other hand, what is recommended now is hip-safe immobilization, which implies that the infant should be immobilized in such a way that unhindered hip flexion and abduction and knee flexion is allowed. And such positioning can be achieved by performing hip-safe swaddling or by carrying the babies in simple baby-wearing devices. And this positioning has been shown to be protective against the development of DDH. We recently wrote up this review article in which we have reviewed all the literature regarding the advantages or the virtues of hip-safe positioning in the postnatal period. And this has been published in the recent edition of IJO. And if you look at it, there is a significant amount of literature in favor of safe positioning. For example, if you look at populations such as the Chinese populations and Nigerian populations, which carry the infants on their backs with the hips flexed and abducted, these populations have a significantly lower incidence of DDH. Also, if you look at this study from Japan, so Japan has had a very high incidence of DDH, about 3% till the year 1970. However, they implemented a nationwide public awareness program to spread public awareness regarding the safe positioning. And following that, by 1984, the incidence of DDH in Japan had dropped down to 0.2%. Sadly, in our Indian scenario, the awareness regarding hip-safe swaddling is very low. And in this review, survey article, which was published in IJO about 2 years ago from Wadia, a study conducted by Alric sir and Rujuta madam, we showed that only about 5% of caregivers of infants were aware about the concept of hip-safe swaddling. So this is a message to us that we need to work on spreading awareness regarding hip-safe swaddling. In my personal practice, I always make it a point that whenever an infant visits me for consultation, I speak to the family and discuss with them methods of immobilizing the child in such a way that they are safe to the hips. The next point I would like to touch upon is early detection and specifically development of screening program, which is tailor-made for the Indian scenario. Now, the problem statement in India is that we don't have any screening program whatsoever. And this has resulted in a very high incidence of walking age DDH. All of us who are here on this panel will attest to the fact that most of the children of DDH that we see are past the walking age group, and therefore surgical option is what is needed in most of these children. So there is definitely a need to push for early detection, which can be achieved through screening. Now, before we go ahead with what type of screening program is suitable for the Indian scenario, let's see as to what are the types of screening programs that are followed the world over. So one type of screening program is the universal ultrasound screening, which is followed in some European nations, notably Austria and Germany. And as the name suggests, this implies hip ultrasound for every infant. The advantage of universal ultrasound screening is that it has a very low incidence of late diagnosis. However, the disadvantage is that it has a high chance of over-treatment of hips, which would have otherwise resolved spontaneously. Additionally, this screening program is simply not feasible in the Indian scenario, where there is a lack of resources and there is a lack of trained personnel. The other type of screening program is universal clinical screening, which consists of multiple serial clinical examinations for every infant. And this clinical examination must consist of ortolani sign, Barlow sign, restrictive hip abduction, asymmetrical skin folds, and limbal discrepancy. However, the disadvantage is that in the hands of an inexperienced examiner, some cases of DDH may be missed if we resort to just universal clinical screening. So the selective ultrasound screening is somewhat of a middle path between universal ultrasound and clinical screening. Here, you do a clinical examination for every infant. In addition, infants who have abnormal clinical findings or who have one of the risk factors, namely breech presentation, postnatal restrictive swaddling, and positive family history, they are referred for ultrasound screening. So, which of these screening programs is suitable for India? The answer is that we need to develop a screening program which is tailor-made for our circumstances, as has been actually put on by Dr. Ashok Johri in this recently published editorial. And work on this is already underway. So this development of DDH care pathway specific for India, it was started by two professional organizations, namely the Pediatric Orthopaedic Society of India and the Indian Academy of Paediatrics. And subsequently, the support of 5 more professional organizations was enlisted. Representatives from these 7 organizations then went through a 3-phase stringent process in order to develop a consensus statement. And at the end of this process, a 35-point consensus statement was laid out. I am just reiterating a few points from this consensus statement. So what this consensus statement states is that every infant should undergo serial exams for DDH. This in order to ensure penetrability into the remotest of rural areas. Field workers, namely ANMs, ASHA workers, RBSK workers, they can be trained in clinical examination of the hip for DDH. In order to make sure that none of the infants are missed in the screening program, the clinical exams can be integrated with immunization program or well baby clinics. And considerable flexibility has been permitted with regards to choice and timing of imaging modality. Now, in our country, ultrasound is not available in many places, and therefore X-rays can be acceptable in areas where USG facilities are not available. Now, 2 points I would like to further elaborate on here. One is regarding the need for serial exams. Single exam is never enough for a diagnosis of DDH in infants because there can be 2 fallacies over here. Number one, that DDH may be missed on single exam even in expert hands. And number 2, it has now been well proven that hip diagnosed as normal in the neonatal period have some risk of deteriorating over time. And therefore, it's very important that clinical examination for DDH should not be a single point examination, but it should be a serial examination. Regarding the use of X-rays for diagnosis of DDH in infants, so dysplasia is traditionally graded by the Tonnes classification. However, one important drawback of the Tonnes classification is that the bony landmark that is used over here is the center of the ossific nucleus, which in cases of DDH may be delayed or may be smaller. In order to overcome this problem, the IHDI classification has been proposed, in which case the reference point, the bony point, is the midpoint of the proximal metaphysis. The last point that I would like to emphasize over here, which can be a practice-changing idea in DDH, is the emergence of global collaborations through the International Hip Dysplasia Registry. So the IHDR is basically a registry which has enrolled 29 high-volume centers worldwide in 8 countries. I'm proud to say that 5 of these centers are in India, of which one of the center is Wadia Hospital at Mumbai, with Dr. Alric Arogis being the chief coordinator. 4,000 plus patients have already been enrolled in this registry. And with this huge amount of high-quality data, this registry is ideally positioned to carry out targeted hypothesis testing on long-standing areas of controversy. For example, what is the role of bracing in acetabular dysplasia? Or does the acetabular remodel sufficiently after hip reduction in DDH? So these are some of the controversial areas in DDH which are likely to be resolved with studies performed through such kind of registries. I just enlisted a few of the publications of IHDR. They already have 50 plus publications which are listed on their website. So with that, I say that in the coming decade is going to be very exciting. There are a lot of practice-changing ideas that are coming up, and they've certainly promised to change our outlook towards DDH, our ability to detect DDH early and preventing DDH. So thank you so much for this opportunity. I hand it over to you.
Thank you, Sandeep. Thank you so much for that wonderful update on how early and walking age DDH has changed over the years. And we have time for 2 questions for Dr. Sandeep Vaidya. Ma'am, you need to unmute.
I'm already unmuted.
Yeah, ma'am.
Yeah.
So fantastic talk, Sandeep. I think it's really been a perfect summary of what really has transpired in the last 5 to 10 years. Now, with this background, how do you see the way a child will be approached in future, or is already being approached by the PD pods now, when it comes to an actual DDH? Gets what ages were you seeing earlier, and what ages will you see them presenting now?
Yeah, absolutely. So as all of us sitting on this panel today will attest to the fact that we are seeing far too many number of cases in the walking age category than we would like to see. Unlike our Western counterparts who usually do pick them earlier. And I think with if we really stick to this screening program and we implement it wisely, we are likely to catch up with regards to the early detection, and we are likely to see them much earlier. And obviously, there are multiple studies to show that the earlier a child is treated for DDH, the results in terms of long-term results are definitely much better. And therefore, there is significant hope that in the coming future, we will see a decrease in our numbers of walking age DDH and increase in our numbers of early presenting DDH, which allows us to give us a much better outcome in this children.
Yeah, perfectly said. Also, since I'm subject close to my heart, how do you see this changing the actual devices that we use for day-to-day prevention? Do you see a commercially marketable swaddling device now, which may come up in the next few years, or do you think the Pavlik harness is going to remain the gold standard?
No, as far as treatment is concerned, Paulik harness still remains the gold standard. But as far as what you're talking about, the swaddling devices for normal kids, okay, I think that has got to be, see a change. Like commercially, there are not many devices which offer hip safe swaddling. Uh, During the review article that we wrote, I was just searching on Amazon as to the kind of swaddling devices which are available online. And I'm sorry to say that most of those devices which are available online are they promote they create restrictive swaddling and not the hip safe swaddling. So I think once this the awareness increases, more and more commercially available devices are going to be available which are going to permit hip safe swaddling rather than restrictive swaddling. So that needs to change. But as far as treatment of diagnosed cases goes, Paulik harness still is the gold standard, and I think it is going to remain gold standard in the future as well.
Just now there's questions coming in on YouTube. Do you want to read that out to Sandeep?
No, I don't see any.
Or if we are running out of time, I can go there and answer them online.
We have time. We have time. Should I read it out to you? Dr. Suranjan Nag has asked how early and how late should we have X-rays if USG is not available?
Yeah, so X-rays, I think they should be done between 3 to 6 months of age. That would give us a fair idea as to the occurrence of DDH. And with the IHDI classification, which does not rely on appearance of ossific nucleus, where, as I mentioned, the only landmark that is taken into account is the center point of the proximal metaphysis. That is a good reference point, and with that, it increases accuracy of DDH even for the lesser age group. So I think 3 months is a good age for performing. 3 to 6 months is a good age for performing X-rays for screening of DDH, if USG facility is not available. Any other question?
Great. I think, Chasna, let's move on in the interest of time.
Yeah, so there's a slight lag between the live session and the YouTube session. And if we have any questions, we'll certainly take them at the end of this session. And now I invite Dr. Mandar Agashe, and he will talk to us about slipped capital femoral epiphysis and how the practice has changed.
Thank you very much, Chasnal. Thank you to Bombay Orthopaedic Society and the convener of the Masters Series program, Dr. Rujita Mehta, who is the Vice President of the BOS. I'll be talking to you about slipped capital femoral epiphysis. What I'll be talking to you is what we know and what a few articles have done to change the practice of management of this very difficult problem. So as we know, slipped capital femoral epiphysis is an adolescent hip disorder with a varus and posterior slippage of the capital femoral epiphysis. It's one of the commonest conditions causing early hip arthritis in young adults. It's basically a slow type 1 slip between the proliferative and the hypertrophic zone of the physis, with a strippage of the anterior periosteum, where the epiphysis displaces posteromedially, which leads to the proximal femoral metaphysis impinging against the acetabulum, with resultant cartilage and labral damage, with long-term risk of FAI and degenerative joint disease. We know a few classifications. The earlier classification was the temporal classification, where it was divided into pre-slip, acute slip less than 3 weeks, chronic slip of more than 3 weeks, and acute on chronic slip, where the duration was more than 3 weeks, but with an increase in symptoms. However, this did not predict risk of AVN. And what really changed practice was this article by Randall Loader in 1993, where he classified slips into stable and unstable, where stable was where the child was able to bear weight, and unstable was where he was unable to bear weight. And this was extremely predictive of AVN, where a stable slip had a risk of about 1% and an unstable slip had a risk of very high, which was almost 50 to 60%. The severity classification was by Southwick's, where he classified into mild, moderate, and severe, depending on the amount of severity. Whatever the treatment may be, we should know our goals of treatment. We should know that it should prevent further slip progression, restore proximal femoral anatomy, and prevent complications of avascular necrosis, femoroacetabular impingement, and finally degenerative joint disease. With that in mind, let's see what treatments we know and how that treatment has changed over time with a few articles. There are a few options. We have in situ pinning, we have closed reduction with various means, we have open reduction, and finally we have safe surgical dislocation with the modified Dunn approach. What exactly is in situ pinning? In situ pinning, as the name suggests, means that there is no attempt to reduction and the slip is not reduced at all and it is just fixed in situ. This is in situ pinning, and this is a very, very good method for mild to moderate slips. And this has been a gold standard for many, many years. It's a percutaneous technique. It has lower operative time with blood loss, and it basically prevents further slip and further deformity. This can be used for mild to moderate slips, and there are some people who use it even for severe slips. And there have been a number of articles. One of the most practice-changing articles in the early 90s was this article, which showed the long-term study of slip capital femoral epiphysis, which showed an excellent result at 38 years. You can see that this was the case they had shown, which showed a good result. However, we know that this is a case where there is a big cam deformity, and this should ideally require treatment. How has in situ pinning changed over time? Well, there have been good results of in situ pinning over time. A recent article by Dennis Wenger showed that in situ pinning remains a safe and very predictable method for treatment of stable slips with no AVN, even in severe slips. So they recommend doing in situ pinning even in severe slips. However, in situ pinning is extremely difficult. And a very good article by one of my co-faculties, Dr. Prasad Gaureli, has really changed our management of in situ pinning. What is that? What he recommends is that we have to pass the screw obliquely, not perpendicular to the fracture site at the neck, but almost at the intertrochanteric line or even lateral to it, so that it will enter the physis right at the center, but it will be directed slightly superiorly. It passes right through the posterior aspect of the femoral neck and goes to the center of the neck. So this is an easier trajectory to put, especially in severe slips, and has resulted in good results over many articles. Whether single or double screw is quite a bit of a debate. Overall, what we say is that you have to put one screw for a stable slip and two screws for maybe necessary for unstable slips. Is there any role for closed reduction? Where over time, there were methods of closed reduction. There were methods of what we call a gentle, incidental, serendipitous reduction. However, nowadays, they are not practiced. But what is practiced is a method which was described in 2009 by Klaus Parsch from Germany. This is known as open reduction and smooth K-wire fixation for unstable slips. What he says is that you have to do a small open reduction through the Watson-Jones approach. You have to reduce to a level prior to the acute episode. So this is for an acute or chronic unstable slip. It's a gentle reduction with a very low AVN rate of only about 5%. This is the illustration which they have done. So just to explain, so if you have a slip like this, which is a chronic slip, where there's a lot of callus, and suddenly the child falls down in order to form an acute or chronic event. So what you do is just reduce it to the level prior to that acute episode. So reduce it partially through an anterior approach and then fix it with a screw. So this is how it is. You can see that there's a lot of posteromedial callus, which shows that it's an acute or chronic slip. You reduce it partially and fix it with a screw. So this is what is Parsch method. A recent article in 2014 by Dr. Dennis Wenger had a very, very good point. A likely safer modification is to open the joint anteriorly to decompress it and to stabilize it after reduction as described by Parsch. So Parsch method is one thing which everyone has to learn. This is really a practice-changing concept where you go anteriorly, do a capsular hematoma drainage, do a gentle anterior reduction and pass a screw only to the level of chronicity. Another concept is something where you do an anterior in situ fixation with an anterior osteoplasty. However, we still do not have enough evidence to recommend this. What is done in some cases is an anterior approach where you do a cuneiform osteotomy. Now, this method involves a lot of shortening of the neck with a resultant danger to the extensile retinacular blood supply. This was described way back in 1960s by Dunn, later on modified by Fish. Initially had a very low AVN rate, but this was not replicated by other authors with an AVN rate of almost 40%. What changed then? Well, in the early 2000s, the Renaissance man from Bern, Dr. Reinhold Ganz, ushered in the modern era of hip preservation. Hip preservation is going to be a topic which is going to be described in detail by Dr. Prasad Gaurineni. But what Dr. Reinhold Ganz described in his first article, where he described the anatomy of the medial circumflex femoral artery, was really practice changing for the management of slipped capital femoral epiphysis. He extrapolated this knowledge of the anatomy of the MCFA to these three landmark articles about the surgical dislocation, about the periacetabular osteotomy, and the femoral acetabular impingement. In our case, this article was the most important. He really revolutionized the treatment of severe slips by this concept of surgical dislocation, which he used for moderate to severe slip capital femoral epiphysis by a procedure known as a modified Dunn procedure. This improved the safety of the Dunn subcapital realignment with the surgical dislocation approach, with the help of the extensile retinacular flap and the subperiosteal exposure of the femur for reduction and fixation. What it does is that you do a trochanteric osteotomy, dislocate the hip anteriorly, create an extensile retinacular flap, remove the posteromedial callus and also a small amount of the neck, reduce it, fix it with a screw and K-wire, relocate the femoral head, and fix the trochanteric osteotomy. A few clinical pictures. You can see it's a lateral approach. Once you cut the fasciolata, there's this digastric flap of the trochanter, which you dislocate anteriorly. The hip is dislocated anteriorly. You can see after the capsulotomy, a severe bump with the posteromedial displacement of the neck of the epiphysis. The retinacular flap is released well. A small osteotomy may be required, especially in chronic slips. The head is relocated well, all throughout, keeping the bleeding head intact. This is the reduction after fixation. You can see at 1 year post-op, this is an excellently reduced head with no avascular necrosis. This can be done in unstable slips. It's a highly technically demanding procedure. It has to be done with the operating staff room, which was familiar and prepared for the procedures. We still don't have long-term results, but we do have results for about 5 years and 10 years post-op. However, it should not be done. It should be done very carefully with stable slips. It should never be done with minimal training, and it should be never done in an emergency with non-orthopedic staff. We are lucky that we got good experience with this. We have published one of the biggest series of modified Dunn osteotomy for moderate to severe SCFEs from India with me and Dr. Sandeep Vaidya. And this is one of the results showing excellent results at 4 years. Thus, finally, take-home points. It depends on the severity and stability of the slip, and it has changed over time. For mild to moderate slips, in situ pinning still remains the gold standard, though the practice-changing article was an oblique screw fixation by Dr. Prasad Gaurineni. The incomplete acute reduction and pinning method of PARSH has shown good results for acute on chronic slips. And the modified Dunn procedure has really revolutionized the treatment of moderate to severe slips, though it has to be performed only after adequate training. Thank you very much.
Thank you, Mandar. Yeah, that was a wonderful talk. And there are a lot of questions about the technique here, and yeah, we have some time and we can take some questions. So one of them is, what kind of operating table do you use? Is it a fracture table or a regular table?
So again, there's a lot of controversy about what sort of table needs to be used. I am personally in favor of using a simple radiolucent table for fixation of slip. In case it's a very unstable slip, then I use a fracture table, but that too with extreme care. I don't want the OT technician to internally rotate the leg very forcefully, just like it is done in an intertrochanteric fracture. So even if you are using a fracture table, it has to be with utmost care so that internal rotation is strictly avoided.
Yeah. And second is, do you rotate get a frog leg lateral position for a C-arm view?
Yeah. So what typically needs to be done is that the child has to be slightly inside the OT table. It should not be at the edge. And what you do is you do an AP view, and after which you just flex and external rotate only slightly. And the remaining external rotation is to be done by compensatory movement of the C-arm. That is why the child has to be right in the center of the bed. Otherwise, the peripheral bars of the OT table come in the way. So you should never do a complete external rotation of the leg. Otherwise, the wires typically bend. So it's typically just flexion and slight amount of external rotation, and the C-arm tube moves in a compensatory manner.
Continuing with this same point, preoperatively, many a times we see patients come with just a PBH AP view. So is a frog leg view recommended to begin with, or what should be the advice?
So for every suspected slip capital femoral epiphysis who's stable, if we are talking about stable slip, I do an X-ray pelvic both AP view and a frog leg view. Along with that, I do a CT scan. In case it's an unstable, there's an echo somewhere.
Yeah, there's an
on. Yeah. So in case there is the child is an unstable state, I usually get whatever X-ray is done. I don't trouble the child by doing a proper frog leg view. It's just an AP view of whatever view it comes, because it's going to be extremely painful. And my doing an induced frog leg lateral view itself can cause increasing avascularity of the femoral head. So it's just a AP view and a CT scan.
And last question is, what is your preferred approach? Smith-Peterson or Watson-Jones? And does it change in acute cases and in chronic cases?
So in case I have to do an in situ pinning with an anterior osteoplasty, then probably it's an anterior Smith-Peterson approach. I go directly to the front of the neck and do an anterior osteoplasty. In case it's a moderate to severe slips, I usually go by the lateral, that is a safe surgical dislocation approach, and do the modified Dunn procedure.
And any role of contralateral pinning? Of course, a controversial question.
Again, quite controversial. Theoretically, we say that contralateral pinning needs to be done where the child is very young. There's a lot of endocrinological issues. The child is extremely obese with a BMI of more than 25, or if the follow-up is very irregular. However, in India, it is any which way difficult for us to convince the patient to pin the ipsilateral side, which is the affected side. It's extremely difficult for us to convince the parents to have something done for the normal side. I usually try to convince them. I don't force them. I give them an option that there's a 20% chance that he may have a contralateral slip, especially if he is very young. If the parents allow them to be treated with a contralateral pinning, nothing like it. Otherwise, I basically tell them is that see to it that you keep on following with me every 6 months or so, or if there is any hip pain in the contralateral side.
And last question, because we are done with the time. How bad is the limp if the neck is shortened?
Yeah, so usually it's not a very big shortening of the neck. It's probably not more than half a centimeter or so, which is required, especially in a surgically dislocated hip. So usually the limp is extremely minimal due to the shortening. I don't think that there's a limp because of the shortening at all.
Yeah, so thank you so much. And now we have the master talk from the master himself, Dr. Prasad. Thank you, sir, for joining us. And sir will be highlighting on adolescent hip preservation, adolescent dysplasia, and femoroacetabular impingement. So over to you, sir.
Thank you, Jasnal. Rujuta, thanks for inviting me. Greetings from Chicago. Okay, I started somewhere in the middle. Stop. All right. So hip preservation itself is a practice-changing idea, if you allow me to say that, right? FAI is a newer concept. So most of the things I'm talking about have increased the awareness already in some people, but need more awareness in others so that we don't miss diagnosis and treatment. I'm going to talk about hip preservation as an a few slides on introduction, explain a little rational approach, because we don't want to fix every abnormality we see on X-rays. We need to understand which ones are clinically important, and then show you some established indications and the outcome studies we have so far. So hip preservation is any surgical intervention to maintain or restore normal native hip function. Most of us have been already doing hip preservation before GAN. VDOs, valgus osteotomies, core decompression, Salters, they're all hip preservation surgery. But the newer techniques like cam osteoplasty, vestibular rim trimming, head and neck osteotomies, all developed by Reinhold Gahn, those are really, brought in a newer field called hip preservation as a specialty in orthopedics, pediatric orthopedics especially. So how did Gahn go about doing this? He came up with a newer osteotomy. It's not new anymore, it's 1984, pre-established osteotomy. Then he found hip impingement as he overcorrected the established. He was able to get so much correction with this new technique. A new problem was discovered called impingement. Then to solve the impingement problem, he developed an SSD, safe surgical dislocation, which only means that the surgical approach is safe to the blood supply. It doesn't mean that everything you do through SSD is safe, it's just that approach is safe to blood supply. Then he developed newer procedures like head reduction osteotomy and improved on older techniques like modified Dunn. Then arthroscopists took over, and everything we do open is now trying to be done arthroscopically. So what is the significance of this topic, hip preservation? Mechanical hip pain is often pre-arthritic, even when the symptoms are mild. So don't wait for severe symptoms. Subtle clinical and radiographic signs can be very significant. And timely treatment, most important, is can decrease pain, improve function, and prevent or postpone arthritis, right? So it's important to identify the problem and treat at an early stage. Here's a few examples to drive home that point. Some say mild dysplasia on the left side with subluxation. Observed over a period of 6 to 12 months, this patient developed significant arthritis. It is a mild slip, right? You all agree that this is pretty mild. The 26-year-old cast technician in my hospital, almost bone-on-bone arthritis at 26 years of age. Protrusio is well known to cause arthritis. On the right side, it's milder arthritis. On the left, it's more severe arthritis in a younger person. Well, the total hip is considered to be the operation of the century, last century, because it revolutionized treatment of hip pain. But it's not so good for young people. Even a 10 years follow-up in well-done ceramic and ceramic implants, 15% revision rate. And if you add on people who haven't had the revision but don't do too well with pain and loosening, the failure rate goes higher. More importantly, the second revision doesn't do as well as the first operation. The revision doesn't do very well as the primary operation. So don't do total hips unless the hip is not preservable. So what is preservable? What's a preservable hip? You need to have good joint space. That means good cartilage. Without good cartilage, you can't preserve a hip. So good joint space, good cartilage. Good cartilage means it's a preservable hip. And keep in mind that arthritis depends on not only hip morphology, it's activity level of the patient. So you're not going to do the same operation as somebody who's sedentary compared to somebody who's quite active. And individual biology. Not everyone with a cam bump is going to get pain or arthritis. So we need to pick and choose who's going to get into trouble. So here's a rational approach I want to introduce. So we want to identify all potential causes of hip pain, right? Treat either the most likely cause, or if you're doing something like SSD, safe surgical dislocation, you can comprehensively treat everything without taking extra time or extra incisions or extra implants, right? So two approaches. Either arthroscopically address one or two things, or comprehensively fix the hip if you can identify all the problems. And treatment should always be based on risk-benefit analysis to that patient in your hands, not based on what Gahn's got in his results. It should be how you're doing in your location. And an important factor is none of the modern hip preservation techniques make a future reconstruction harder. So you want to make sure that a future total hip, which is inevitable in a lot of these hip conditions, won't be made difficult. So the tools for evaluation today we have are HNP, which is very important to diagnose impingement. Impingement is a purely clinical diagnosis. X-rays are critical, because they give a global picture and often adequate for treatment. MRIs to rule out other causes or advanced damage. Labral tear is not a diagnosis, it's just a finding. And CT shows bony morphology quite well. If you're confused or want better detail of the bony morphology than an X-ray, go ahead and get a CT. And diagnostic injections, you don't identify the source of pain. Classic clinical exam on the left is an impingement sign that passed in almost all hip conditions. On the right is the anterior apprehension sign. Here's a standard pelvis AP X-ray. A lot of lines you can see. You can see that you can get a global idea of the bony morphology. You can see retroversion, you can see over coverage, you can see cam morphology. A lot of things can be seen very well on a plain X-ray. So here's what's important. I mean, this is what I found to be important. You group problems based on hip function. So the causes of hip pain can be divided into 4 groups for me. It is a cartilage problem in the weight-bearing area, like OCD or a loose fragment between the joint surfaces. Is the hip unstable? Is it stylodysplasia, coxa valga, which can cause these problems? Impingement can be caused by a host variety of things, vera, breva, plana, profunda, pretty much everything can cause impingement. So you don't treat X-ray abnormalities, you make the diagnosis clinically, and then try to correlate what you see on X-ray with the clinical exam. Of course, abductor dysfunction by coxa vera, breva, even coxa valga can cause dysfunction. So that brings us to thinking about hip function. And what I found is these are the 4 elements of hip function that you should look for each time, so that you don't miss an important part of hip function. You need healthy cartilage in the weight-bearing area at the top, right? You want nice cartilage. Stable head in the socket. You don't do any surgery that can make the hip unstable. You don't cause impingement that's not there already, but you want to correct these problems if they're existing, and then end up with good abductor function. So what's the reason to divide them into 4 of these? Because it allows you to correlate your clinical exam with X-ray findings so that you won't miss important aspects of hip function. And you don't cause untoward consequences with your treatment. For example, coxa vera. You may see coxa vera on X-ray, but clinically no problems, no limp, no impingement. Then obviously you're not going to do anything for it. Coxa vera prevents lateral subluxation in the face of stylodysplasia. If you see coxa vera and stylodysplasia, you probably can leave them alone because they don't have subluxation. But if you correct coxa vera in the face of stylodysplasia, you can make things worse. Impingement, somebody's impinging already. Coxa vera is producing osteotomy is not a good idea. So you don't want to correct coxa valga and cause coxa vera. You want to relieve impingement without adding more veras. If somebody has abductor weakness with coxa vera, you're going to correct that with different procedures. So FAI simply is not just one diagnosis. It's pain and dysfunction of the hip from normal movement. It has to be movement induced, right? Movement induced. From abnormal shape, size, or orientation of the femur or the acetabulum. So it's like pain and dysfunction from normal movements of abnormal bones or the proximal femur. And the abnormality can be very subtle. It's not like a big SCFE or a protrusia all the time. A few examples. AIIS impingement from overgrown AIIS. Lesser greater trochanteric impingement like in old Portis. Lesser trochanteric impingement against the ischium here. All these forms of extraarticular impingement squeeze soft tissues between the bony prominences. The treatment is to increase the space. Intraarticular, you have the classic cam impingement, a spherical femoral head, squeezing itself into the hip with flexion and causing cartilage damage. And you can see a herniation pit on X-ray where the sphericity is contacting the acetabulum. Early damage, right? This may look like normal hip to you, but that's soft cartilage. A teenage boy should not have soft cartilage like that. If you don't treat it appropriately, flaps of cartilage start coming off. So treating even subtle impingement becomes important to prevent further damage. Here's a little video to show what CAM does. Bump on the neck, flexion and internal rotation cause a labral and cartilage damage. A very exaggerated CAM deformity with osteophyte formation in a young adult. You can nicely shape it, relieve the impingement. Believe me, this cartilage is healthy. It just looks colored differently with this open exposure. Now you can do this arthroscopically, the CAM deformity in a young teenager. You can do a nice osteoplasty like that to relieve the mechanical problem. Dispenser impingement, where the labrum is getting crushed between the femoral neck and the acetabulum from over coverage or retroverted acetabulum, retroverted femur. Here's the damage you see. You may think it's not too bad, but the labrum is getting crushed in a young person, in a teenager. And the procedure to do is to trim the rim if it's excessive, repair the labrum back, and do an osteoplasty if there is CAM, which is often there in most hips. You can do all this through small incisions arthroscopically, but it's very good, very safe to do it through an open operation too. Here's another example of impingement called foveal impingement. Here's a deformity. I showed this X-ray several times to most of you. Caput valgum, head is in valgus. Coxa vera, non-existent neck, right? So that's the medial aspect of the sore seal. That's lateral aspect of the fovea. So the fovea is in contact with the sore seal. That's the lateral aspect of the sore seal. Lateral head. See how much head is outside the hip. It's not even healthy head is not being not articulating with the acetabulum. And the problem here is the ligamentum is getting crushed between the head and the acetabulum, the sore seal. The treatment here is relative neck lengthening, advancement of the great trochanter to create a neck, and then varus osteotomy to move the fovea down and put healthy cartilage against healthy sore seal. Mandar showed some examples already, bilateral SCFE, moderate to severe. These kids have clinical problems. They can't even sit properly, upright. You get the obligator axial rotation deformity. Even the hip is not even to 90 yet, but look at how much axial rotation the hip is going into. So this needs to be corrected to improve function. It's any type of osteotomy. And like Mandar does, due to the modified done osteotomies, they're mixed review. Some people had very bad experience with done osteotomies, some had very good results. And our experience has been quite encouraging. This is a 5-year follow-up of the child with bilateral done osteotomies. Doing quite well. Interesting topic. Here, the coxa magna and plana on the right side. I don't know if the X-ray is showing well for you. Here's the paper cutout. So the big head not fitting the acetabulum, subluxated. You can remove the central 1/3 and make the head nice and round and small, called central head reduction osteotomy, pretty much made up by Professor Gant. The clinical example of a head, central 1/3 or few millimeters is being removed after protecting the blood supply. The segment removed, the two halves of the head put together. Sorry, Chasnell, you said no blood, but what's orthopedic surgery without some blood? That's labrum, head is reduced, and the head is bleeding actively. Last example in FAI, 16-year-old female with the right side impingement, retroverted acetabulum. Here, the choice was to do an anti-verting PAO to correct the impingement. A few slides on dysplasia. Summary slide, one slide. Dysplasia essentially decreases the weight-bearing area and causes rim loading of the head and the acetabulum, leading to labral tears and pain. Arthritis can set in very fast. I've seen reasonable-looking hips get bad arthritis within 6 to 12 months. So dysplasia or subluxation is a very strong risk factor for arthritis and should be treated promptly. And results are better with early correction. Like anywhere, if you allow damage to happen, the results won't be as good. Example of pretty significant dysplasia is subluxation, broken Shunton's line, very steep acetabulum. You can get a very good correction with the acetabular reorientation, right? This is a Gans osteotomy done, almost horizontalize the sore seal, right? But keep in mind that the coxa valga was ignored because the coxa valga, if I correct it into varus, it will cause impingement. So we left the valgus and corrected the acetabulum adequately to compensate for the valgus. Here's a Chiari osteotomy you can do in a non-congruent hip. And here it's the capsule is being supported by the ilium. Shelf, similar idea. The capsule is being supported by extra bone you place on top. And here is a colonna with a dislocated hip with no acetabulum to reconstruct. Abundant capsule. You remount a bony acetabular socket with total hip reamers. Put the capsule around the head and put it in. This operation is a very good operation, especially with the modern techniques where AVN rate and stiffness have come down. It's a good operation for hip surgeons to keep in their armamentarium. So outcomes. PIO for dysplasia has very long follow-up, 30-year follow-up. At 30 years, 33% of hips are still functioning very, very well. Not just conversion, functioning really well. And 80% of hips are surviving at 20 years, which is a very good result for a dysplasia that gives arthritis within 6 to 12 months. Then osteotomy, the longest follow-up I'm aware from Switzerland is 14 to 16 years. No conversion, but arthritic changes are seen on X-rays on follow-up. PIO for retroversion, not as good, about 79% at 10 years. Protrusia has the worst results, 51%. Head direction osteotomies, no conversions at 5 years follow-up. A few case examples to put the point that you have to restore all 4 elements of hip function. Here's a right hip dysplasia, subluxation, caput valgum, where the fovea is high, foveal impingement, short neck, vestibular dysplasia. They cover everything by doing a PIO, neck lengthening, trochanteric advancement, and varus osteotomy. Another example, a spherical coxa magna, dysplasia, and coxa vera. PIO, relative neck lengthening. This is a very simple operation to recover from, relative neck lengthening. Another example of the Portis hip I showed earlier, acetabular dysplasia, retroverted acetabulum, non-existing neck, coxa vera, PIO, relative neck lengthening. Thank you very much.
Thank you, sir. And we have a couple of questions, sir. So when would you advise weight bearing, or what's the post-op protocol post the acetabular reorientation osteotomies?
So typically a periacetabular osteotomy, which is not immobilized, right? You put 3 screws in there. The fixation is quite stable. Most of us recommend 4 weeks of non-weight bearing, but some of these children are able to bear weight even sooner against our advice. But typically 4 weeks of non-weight bearing, getting an X-ray, not non-weight bearing, toe touch weight bearing, and getting an X-ray to look for some callus before weight bearing is advanced. And the full weight bearing around probably 8 to 12 weeks after surgery.
Dr. Prasad, I have one question.
Please.
Yeah, so you are one of the very few surgeons who are comfortable with doing hip scopes as well as open hip surgeries. So a question which I want to ask is, when do you decide about when to do a scopy versus when to do a open hip surgery? That is always a question.
Right. So the classic thing is, there are not a whole lot of things you can do with the scope, right? Any of the relative neck lengthening, any osteotomies. I mean, some osteotomies can be done with the scope, but obviously not as easy. So simple things like cam, pincer, moving loose bodies and all are easier to do with scope and are done with the scope. But anything that requires extra articular procedure or major osteotomy are definitely, done through SSD approach.
Even in a simple cam FAI, is there a limit to which you can do through a scope, and you will resort to a surgical dislocation with an osteochondroplasty? Yes.
So posterior cam is not accessible through a scope. Okay. There are people who claim that they can do it. I was never able to go beyond what you can see on the top of the AP. So even then, that's not easy. So big cams that extend all the way back, and you think it's important to resect that cam all the way back, SSD is the best option. When in doubt, go open. If you can do both and you're not sure that you can get everything with the scope. SSD actually is a big incision. but a very soft tissue friendly operation. They recover really fast. The
That's
GT osteotomy heals very nicely. The muscle dissection is very simple. The pain usually is not too bad after 1 week. So SSD is a very good operation.
Perfect.
There's one question, so it's kind of a case scenario that there's a 2-year-old male child post-op, post-septic hip dislocation with a coxa magna. Open reduction was done for the kid, but no acetabular surgery was required. How long do you follow up to consider acetabulum or femoral head surgery? So now post-septic, there's a coxa magna, and how long to follow up before deciding for an acetabular or a femoral surgery?
So if you're able to reduce the head nicely to the acetabulum, the size of the head does not matter anymore. The coxa magna becomes irrelevant if you're able to get the head into the acetabulum. The real problem will be if the magna is so big in a 2-year-old child that I'm not going to do a head reduction osteotomy, how am I going to get the head into the acetabulum? It's important to get the head into the acetabulum. I never had a need to think about head reduction at such a young age, but that'll be the dilemma. Somebody like 6-7 years of age and the head's too big for the acetabulum to put back in, that's where the problem really comes. Acetabular osteotomy, the classic indications are anybody after 2, if they're not improving or getting worse during your treatment, whatever you're doing, whether you're doing a brace or observation, they're getting worse, definitely will intervene on the acetabular side. If they're not getting better, probably I can wait till 3 or 4 years of age with non-op treatment, and they're not getting better beyond 4. You know that acetabular remodeling becomes less and less, the potential, so we intervene on the acetabular side. Head reduction is a difficult operation. Don't take it lightly, and it's probably not indicated in younger people. There are other options to do a Chiari or a shelf to make up for incongruent or subluxated hip.
Okay. Yeah, thank you so much, sir. And we are running perfectly on time. And now over to Dr. Ratna for the next session.
Thank you, Dr. Chasnal. Let's move on. There's a background noise. I think it's from. Let's move on from the esoteric to the more customary primetime TV, a session on trauma and angular deformities. And to begin that, I invite Dr. Taral Nagra to share his screen for practice-changing ideas in upper extremity trauma. Thank you. So you're on mute.
Yeah. I've shared my screen, yet to be seen. Let me try again. All right. So practice changing ideas in upper extremity trauma. And Bombay Orthopaedic Society is all about changing people's practices, through its courses and sessions like this. And what I've done in today's session is very simple. I went through the journals of Pediatric Orthopedics and Journal of Children's Orthopedics 2021. Every article which was on upper limb trauma I've gone through. And from there, I picked up the Shubh number 11, the 11 articles which will change the practice. These papers are stunning. They've changed my practice, and I'm sure once you listen to this will also change practice of the people who are attending today's session. So, I thought that I mastered the art of supracondylar fracture fixation, and then I had this paper. 1 second, there is little lag. Okay, so use of hypodermic needle to guide K-wire placement in pediatric supracondylar fracture. A fascinating idea, a very simple idea which has been published in Journal of Children's Orthopedics. And what they do, this paper from Los Angeles, is that they use a hypodermic needle, put it from the lateral condyle, the lateral surface, and use that as a guide to put your K-wire. So once you confirm the position of your guide for the K-wire on APN lateral X-ray, after putting a hypodermic needle, you put a K-wire then parallel to this with little adjustments. And in subsequent 3 cases, which I've done, once I read the article, I found it very, very easy to do the wires. Now, the difference between passing a K-wire is that you're holding a very heavy drill and there is a K-wire and it tends to lose its position. With hypodermic needle, it's very easy to get to an entry point and push the hypodermic needle through a cartilageous area. And utilization of these techniques, as the article says, has potential to refine surgical technique by minimizing errant wire passages, reducing radiation, and reducing operating time. The second article is about supracondylar fracture in older child. Now, and if you have a kind of fracture, so plating or pinning. And the answer comes from this article from Canada. They say that close reduction and percutaneous pinning of extraarticular fractures in older children is a reliable option, regardless of stage of skeletal maturity. And what they say is the way you will do pinning differently is that you have to have optimum pinning technique with adequate pin spread and bicolumnar fixation. So fixation like this, where you have 2 lateral wires which are diverging and a single wire which goes medially. If you do that with a good reduction, in a close reduction, and pinning will help even in older supracondylar fractures. Open supracondylar fractures, are they different? Should we be more careful in these cases? And this article from Pittsburgh, published in Journal of Paediatric Orthopaedics, it tells us that open supracondylar fractures are more associated with nerve injuries. Experience also in very few open supracondylar fractures which I've treated, nerve injuries are always associated. Ipsilateral fractures of humerus or forearm are common, and in few of them, a vascular procedure or a compartment release also may be required. Now, post fracture union in forearm fractures, refracture is very common. And some of us, we have been giving forearm braces, especially for children with ADHD, to prevent a refracture. Is this a good practice? Is it really required? So this paper from Minneapolis, it says that extended fracture bracing following a period of cast immobilization did not lead to statistically significant difference in refracture rates. So, what we believe and what has been published in the books, bracing for forearm fracture to prevent refracture doesn't hold true. It has severe cognitive issues. Displaced medial epicondyle fracture, to fix this or to leave it. It's a big dilemma, a challenge all over the world. And this topic has been discussed in innumerable debates. And what is the take on this? This paper from Spain, the sports capital of the world, it says that there is no association between magnitude of displacement of medial epicondyle and objective outcomes. So whether medial epicondyle is displaced 2 millimeter, 5 millimeter, or 10 millimeter, that does not decide your management. Then what does decide your management? You will operate only if there is absolute indication like entrap fragment or a fracture dislocation. If there is a high energy trauma with associated lesions. This is very important. Dominant elbow in a patient who's subjected to activities with chronic valgus stress. So if you have a tennis player who's young and he gets he gets a medial epicondyle fracture or a dominant elbow, that may be an indication to fix that medial epicondyle. And lastly, something which is very important, anterior displacement of the medial epicondyle. And this can be diagnosed only by doing a CT scan. So what I've learned from this paper is that medial epicondyle fracture, even displaced. Now, after reading this article, courageously you can consult. You will do a CT scan to rule out an anterior displacement and ask history. What is the child an active sports player, and if that is a dominant elbow, and that will tell you whether you want to operate that medial epicondyle or not operate. The next paper is about patient position for open reduction of medial epicondyle fracture. This is in cases where you have to operate. And I remember Dr. Song, when he came to India, he had done surgery at Hinduja Hospital, where he put the patient in prone position and operated the medial epicondyle fracture. And we were always wondering, is that an approach which is more beneficial? And this paper tells us that the length of surgical procedure did not differ between the two positions. The clinical outcome did not differ. So if prone position is an additional anesthesia problem, if it takes additional time in the operating room, it's not really worth doing it. So supine position is good enough, when you are treating medial or epicondyle fracture by an operative mean, and it will be as good as a prone position. Another debate, displaced mid-clavicle fracture in adolescents, and there has been a trend towards fixing this. Should you be fixing this, or you can treat this conservatively? Again, a big question, and this paper from Norway it tells us good long-term functional results after plate fixation, after IM nailing, and non-operative treatment. There was no additional benefit of surgery. Non-operative treated patients were more satisfied with the cosmetic results because there are no scars, and there is little difference which is seen between fixing with a plate or an IM nail. So what they conclude is surgery should be rarely be the choice of treatment for displaced midshaft clavicle fracture in adolescent. And I'm going to follow this, not to operate clavicles in adolescents unless it's an open injury. Now, this is something revolutionary. Monteggia with complete ulnar fracture, we were always told that they need fixation, length, unstable fractures, you need to nail or you need to plate if there is a long oblique or a comminuted fracture. But a completely different take on this fracture from UCLA. They compared the patients which were treated in plaster and with fixation, and they concluded that even in presence of complete ulnar fracture, so we are not talking about green stick, we are not talking about plastic deformation. In presence of a complete ulnar fracture, a trial of non-operative management of acute pediatric Monteggia fracture with close reduction and casting can result in comparable results. And you must give it a try. So the plate and pins have a second sort of a choice now. A primary choice of treatment in a Monteggia with a complete ulnar fracture will now be a trial of plaster. And only if there is a loss of reduction at 1 week X-ray, you will fix that ulnar. Now, a few more revolutionary papers here. I think 2021 has been full of life and game-changing ideas for pediatric upper limb trauma. Displaced distal radial fracture in less than 10-year-old. This fracture like this, how should you be treating? Close reduction or fixation? So should you reduce and pin it, or accept the bayonet reduction, accept the overriding, just align it and give a plaster in that position? And this seems to be a little far-fetched, but this paper proved that cast immobilization in bayonet position of close overriding distal metaphyseal radial fracture had similar outcome as reduction and pin fixation. And I would definitely recommend that if your child less than 10 years has just maintain the alignment and give a slab or a plaster, and that child is going to do well based on this research. So displaced fracture of distal radius in older children, a fracture like this, should be fixing or just do a close reduction and plaster? Okay. So again, this paper from China, from JPOB, it says that although the post-reduction quality was little better and radiation exposure was less in close reduction and pinning group, there was no difference in the two groups in angulation, total immobilization time, and complication rate after 6 months. So though the initial X-rays didn't look very good in close reduction and plaster, at 6 months, they all became absolutely fine. And what they said is cost and time absent for school for non-operative group was significantly lower than the operative, which means they recommend that close reduction casting is recommended in complete distal forearm fracture in children 8 to 14 years old. So we are going back to conservative treatment for a lot of these patients. And the last paper, minimally displaced lateral condyle fracture, again a dilemma to whether to pin or to put plaster. Some people feel that this is a fracture of necessity, and all of these patients should be pinned. And what is the take this in upper limb trauma. So they said that 37% of non-operative children require a revision treatment in form of pinning. And they further clarified that fracture displacement greater than 1, but if the fracture displacement was less than 1.2 mm, the failure rate was just 1.3, which means if the initial displacement is less than 1 mm, put them in plaster and take a check X-ray at 1 week. But if the displacement is more than 1 millimeter, those patients should be either closely observed or done pinning on the day 1. So these are the 11 sort of a practice changing ideas which we are discussing. The first one was, the second one is close reduction and pinning for older supracondylar fracture, working well. Open supracondylar fractures, be cautious, look for nerve injuries and ipsilateral fractures. United forearm fracture, no bracing is required to prevent refractures. Medial epicondyle fractures, definitely you can give conservation a chance there. When you operate medial epicondyle fracture, supine position is good enough. Don't go for prone position. Clavicle fractures in adolescent, you can conserve. Montagia with complete ulnar fracture, very important, can be treated in a closed manner. Bayonet reduction for distal radial fracture, less than 20 years. Don't know children more than 10 years. Again, a treatment of choice. And lastly, fixed lateral condyle fractures displace 1 to 2 mm. But if displacement is less than 1 mm, you can conserve them. So with this, I end the 11 life change, practice changing ideas. And if there are any questions, I'm happy to see.
So we'll be taking the questions at the end. There are numerous questions coming in. It was a very succinct talk and a great summary of the current evidence base. So we'll hold on to those questions and come back to it. I'll now invite Dr. Swapnil Kenny to speak on practice-changing ideas in lower extremity trauma. Thank you so much, sir.
Theme of which is practice-changing ideas in pediatric orthopedic practice. Now, if you look at the practice of pediatric orthopedics per se, the year 2001 to 2021 can be considered as a renaissance period in pediatric orthopedics. From the time I started my pediatric orthopedic practice, 2005 to 2021, there have been certain path-breaking things which have changed the way we have looked at pediatric orthopedics and the surgery and treatment of children with orthopedic needs. There have been the 3 I's, which are the implants, innovation, and imaging. And over and above that, there is a T, which I'm going to be speaking about later. Looking at the implants, for femoral shaft fractures in children over 5 years, in the last 10 to 15 years, there have been an evolution of various implants, including the elastic stable intramedullary nailing, the external fixator, and the submuscular plate. If you look at elastic stable intramedullary nailing, it acts as an internal splint. It contains soft tissue damage by being minimally invasive, maintains leg length discrepancy, and is highly effective in polytrauma patients. If you compare it to an external fixator, the results are almost similar. However, there are slightly earlier union rates. Joysticking plus external fixator seems to be the best modality of treatment. An external fixator, along with elastic stable intramedullary nailing, seems to be the dictum of treatment for polytrauma cases. As regards submuscular plating, it has also evolved over a period of time, and I'm going to be speaking about the AO principles of the bridge plate as well as the internal fixator. So essentially, the submuscular plate is a rigid fixation. Early joint mobilization is helped out because of this plate. It gives the least amount of limb length discrepancy and has the fastest union time. So the practice-changing ideas as regards implants is that fixation of femur fractures in children above 5 years is now the norm rather than an exception. It minimizes and it also allows for early return to activity. Now, looking at other implants like the proximal femur plates for proximal femoral fractures, the proximal femoral locking plate has become a game changer for children with proximal femoral fractures. It was originally described for osteotomies. It's a fixed angle plate of variable options. It gives a rigid fixation for various fractures and various configurations. And the stability and early mobilization helps the patient to get away from things like the spica and long-term immobilization in bed. Now, this is an eclectic collection of plates wherein you can have various angles, various lengths, and it is actually something which you can use in a very versatile manner for neck femur fractures, for fractures of the base of the neck of the femur, for pathological fractures as well as subtrochanteric fractures. So it serves as an all-in-one implant for all these kind of fractures. The practice-changing ideas for these proximal femoral locking plates is that it does away with the cumbersome spica, in which reduction is difficult many a times to keep as well as to maintain. Does away with flimsy screws and pins, which are not the best choice of implants in unstable fractures. Is formidable and versatile to pediatric DHS, and is a boon in pathological fractures. The third implant I'm going to be speaking about is for pathological fractures, the fascia-dual rods. Now, these fascia-dual rods essentially are used in the treatment of pathological fractures for osteogenesis imperfecta, congenital tibial pseudarthrosis, and many other pathological fractures. So this is a minimally invasive and percutaneous approach implant, which is used by sparing the joints. Hence, it reduces the risk of delayed growth and infection. This instrumentation is much better than the previous basic Dubo-Bailey instrumentation set, which were the telescoping nail, as in it is a much more versatile implants. You get it in various diameters, unlike what you used to get in the previous implants, and the length of the female part can actually be controlled, cut and adapted intraoperatively so that you don't really have to make all your choices before you take the patient on table. The practice-changing idea here is that the revision rates have reduced significantly as compared to the previous implant. The 4-year survival rate is almost 88%. Percutaneous insertion is possible, and there is a significant improvement in ambulation and upper limb autonomy. Coming to the next I, which is innovations and techniques. The first innovation is about hip aspiration in neck femur fractures. Now, hip aspiration in neck femur fractures as a procedure in children is followed commonly as of today. And it suggests that when you aspirate in an intracapsular fracture, it reduces the hematoma, increases the femoral head blood flow by relieving the tamponade, and this is really a practice-changing idea. The second innovation and technique essentially is about the reduction, is about understanding the blood supply of the proximal femur and its reduction in fractures of the femur, and also its implications in trauma. Now that we know what the blood supply of the femoral head is actually like, there are techniques for the safe anterior approach to the hip and the safe surgical dislocation, which can be very useful and assistive in treatment of fractures around the proximal femur, head, and even in the soft tissues around the proximal femur and the acetabulum, if you need to have an open reduction. The next innovation and technique is about the minimally invasive osteosynthesis in pediatric orthopedic fractures. Now, because of evolution in implants, this technique has also evolved significantly. Two things which are important and which have been described by the AO is the bridge plate, wherein you put a contour plate in a patient of a fracture of the lower limb, wherein you can use it to fix a fracture minimally invasively, or you can put a non-contour plate like an internal fixator, which is a locking system, which can also give a rigid fixation. This minimally invasive osteosynthesis has also become a game changer in the management of difficult fractures of the lower limbs. The next innovation and technique is the bone substitutes. Now, various bone substitutes are available today, which were not available in the last 10 years. The structural allografts, non-structural allografts, demineralized bone matrix, hydroxyapatite substitutes, tricalcium phosphates, BMPs, bioactive glass, and growth factors. And all these have actually become the game changers. And the practice changing ideas here is that they're effective for bone gaps and segmental bone losses, provides a large quantum of structural support in pathological fractures. They have osteogenic potential and avoid the need for surgical scars. The next I for the practice changing ideas is the imaging. MRI has become the game changer for a lot of fractures in lower limbs in children. It can pick up occult fractures. In this particular paper of a series of 24 children, MRI of the lower limbs can actually pick up occult fractures in almost about 35% of the cases, most of which were distal femur and tibia fractures. MRI can also be used for post-traumatic fascial injuries, where it can be helped to map the fascial bar, and hence the fascial bars now, based upon the MRI classification, are now divided by Ogden into 3 types. The type 1 is the peripheral bar, the type 2 is the linear bar, and the type 3 is the central bar. The MRI gives a 3-dimensional look to the bone and the fracture and the fascial plate, and hence we are able to pick up these injuries so that they can be treated optimally. The next part of imaging is imaging in pediatric orthopedic sports injuries, and injuries which are very difficult to pick up on other modalities like the X-ray can now be easily picked up and treated, like these osteochondral defects in athletes in the distal femur, or which can be fixed and needs to be fixed arthroscopically. All these can be picked up based upon high-resolution MR imaging. Now, I will come to the last game changer here, which is T. And essentially, it's not about Mr. T, but it's about dealing with it or dealing with IT. And this is to do with information and technology. And this is the biggest game changer, I believe. Today, at the touch of a button, we have so much of information on our hand that it has completely changed the way we look at pediatric orthopedics and the way we look at pediatric orthopedic practice. We have original articles, randomized controlled trials, non-RCTs, clinical trials, cohort studies. We have case control studies, case reports, everything is available. There are certain secondary literature like Medline, PubMed, Google Scholar, Cochrane libraries available. We have all the textbooks, information about drugs, information about implants, treatment guidelines. Everything is available to us at the touch of a button. Technology is also playing its part in being a game changer in pediatric orthopedic practice. And this particular cartoon came in the New York Times about the future wherein a robot is going to be replacing all our joints at one point in time together. And today, we have magical devices like the Taylor spatial frame. We have various applications and softwares with which we can plan the practice of surgery on children with traumatic lower limb injuries. We have apps like the multiplier, wherein we can actually calculate the amount of growth which is remaining after a lower limb fascial injury. And we also have various illustration apps like the one which I have used here, where we can actually use these apps to actually understand the anatomy of the bones of the lower limb, if there are any sort of gaps in it, and also use it as a teaching tool for our residents, fellows, and everybody who needs to understand the concepts of pediatric orthopedics and pediatric orthopedics practice. So as we all know, Moses split the pre-Jesus era. And today, what the game changer per se is what is changing the practice of pediatric orthopedics. It is about the implants, it is about the innovation, it is about the imaging. But more importantly, what we have seen is that we have today moved from one apple to the other. And we need to believe that the apple was always there, but our way to look at it has changed our perspective about game-changing ideas in pediatric orthopedic practice. I thank you very much for your attention. Thank you.
Thank you so much, Dr. Swapnil. It was a very ingenious and innovative talk by itself. I now invite Dr. Vinoti Sheth to speak on advances in the management of angular deformities around there.
So, good morning, everyone. And as we all know that carrying angle of the elbow is required for your clearance mechanism of the forearm during swinging of the arm during walking. This 5 to 15% of elbow carrying angle is sometimes altered, and we see patients who present to us with cubitus varus deformity, mainly resulting from malunited supracondylohumerus fracture, or we see patients with cubitus valgus, mostly resulting from non-union lateral condylohumerus fracture. And for parents, it's almost because of the cosmesis that they present to doctors. But we should understand that it's not just a crooked arm. In case of cubitus varus, the whole of the triceps mechanism is shifted medially. And this keeps on causing an abnormal stress on the elbow joint in simple day-to-day activity like getting up from a chair. This medial shift of the triceps mechanism changes the biomechanical axis, changes the triceps vector, and this causes a chronic stress on the lateral collateral ligament, which eventually gets attenuated, and that leads to what is known as tardy posterolateral rotatory instability. So we must understand and also counsel the parents that it's not just a cosmetic concern, but cubitus varus leads to problems like snapping of the medial head of triceps. This pressure of the triceps medial head on the ulnar nerve can also lead to tardy ulnar nerve palsy. It could lead to secondary distal humerus and lateral condyle fracture, can also lead to AVN of distal humerus epiphysis, and in late adulthood, it can lead to osteoarthritis. Similarly, cubitus valgus is not just a cosmetic concern. It can lead to tardy ulnar nerve palsy, lateral translocation of proximal radius ulna, elbow instability, and can cause elbow pain during sports activity. So another misconception among parents and also among some doctors is that in children, everything heals over a period of time and remodels because it's a child. So does that apply to cubitus varus and valgus? Well, only 20% growth of the humerus occurs from distal humerus physis, and that too almost 65% of growth is complete before 6 years of age. And you must understand that cubitus varus is a three-dimensional deformity. There is hyperextension, varus, and internal rotation of the distal fragment. So it's only the sagittal plane deformities, that is the hyperextension, which is in the plane of motion of the elbow joint, remodels over a period of time if the child is small, less than 10 years. But otherwise, these deformities do need corrective osteotomy. And like any other deformity planning, it requires a proper preoperative X-ray evaluation to calculate the site and amount of deformity. I think most of you must be aware of this classical French osteotomy, which was described somewhere in 1959, which is nothing but a lateral closed wedge osteotomy, keeping the medial cortical hinge intact, and the two screws are passed in such a way that once you close the osteotomy and tighten the screws with a TBW around it, there is some amount of derotation. What is the problem with this osteotomy? What it does is that because of an acute angular correction in one plane, it causes a lateral prominence of the lateral condyle, and this gives a very bad cosmetic result. So even though you have achieved a good radiological correction, clinically it still appears like a pseudovarus. So in order to overcome this, it was described that you should add translation along with angulation in order to prevent this lateral condylar prominence. So whenever you are correcting a cubitus varus deformity, what you do is translate the distal fragment medially, and for cubitus valgus, after you correct the angular correction, you translate the distal fragment laterally, and this would centralize the proximal fragment over the distal fragment and prevent undue prominence. Now what happens here, you have avoided the abnormal prominence of the condyle, but because the medial cortical hinge is not kept intact and you do a through and through osteotomy, this becomes a little unstable osteotomy. So to overcome that, another osteotomy which was described very popular by De Rosa and Graziano is a step cut osteotomy. Here the distal cut of the osteotomy is incomplete, which leaves a triangular spike, and this spike is fitted into the proximal fragment shaved off lateral cortex, and this spike gives some amount of stability through which you can pass a screw and stabilize the osteotomy. Again, you get a good radiological correction, but again, this leaves an abnormal lateral condylar prominence. So some modification was done to this, and a modified step cut, or what is called as a reverse V osteotomy, was described, where a triangular wedge is removed, the distal fragment is rotated, and these leaves behind two spikes on either side, which makes it a sufficiently stable osteotomy and resulting in a reverse V form, as it is called. And this osteotomy is fixed with K-wires with tension bend wire. What are the problems with this? In a very small child, it is very difficult to create a big V because the humerus shaft width itself is pretty small. And because it is a reverse V, it requires a wider exposure, and the fixation of the K-wires, sometimes the trajectory is not adequate enough to give it little more stability. What about cubitus valgus? On similar principle, for cubitus valgus also, Milch open wedge displacement osteotomy is described, where a single cut is made, the distal fragment is then translated laterally, and it is fitted into a small V notch which is created on the proximal fragment, making it quite a stable osteotomy. Similarly, a reverse V, as we discussed in cubitus valgus, a reverse V osteotomy is described even for cubitus valgus on similar ground. And in bigger children, you can fix them with a Y plate, which gives it a sufficient stability. Another osteotomy which was described is dome osteotomy. This osteotomy requires quite a lot of preoperative planning. You need to decide where to make the dome, how much angle to rotate the distal fragment, and a very nice paper from Tian on supracondylar dome osteotomy, which can be used even for cubitus valgus, especially which is resulting from non-union lateral condyle, where first in situ fixation of the lateral condyle is done by a paratricipital approach. Then the osteotomy is marked on the bone. The amount of derotation angle is also marked. And then once you have derotated to an adequate extent, you can fix the osteotomy with K-wires. This gives sufficient stability to the osteotomy. It allows you to fix it with K-wires or in bigger children with plates, and it does not cause any much of a lateral prominence. But it is technically demanding, and sometimes you require a surgical expertise to execute this sort of deformity. So in recent years, in 2019, another osteotomy which is described is an oblique lateral closing wedge osteotomy for cubitus varus. And in this, the distal fragment is made in an oblique fashion. It is not parallel to the joint as it was done in classical French osteotomy, but it is at an angle. And this osteotomy is marked with K-wires. The two K-wires are preoperatively, before cutting the osteotomy, two wires are inserted in the distal fragment. And once you cut the osteotomy, you advance them, and there is enough space for a third K-wire also in order to make it quite a stable osteotomy. So this is the result at the end of it. Because it has a long oblique osteotomy surface, it is quite stable, does not lead to any lateral prominence, and gives good result. There are some concerns about these acute corrections, that when you are doing an acute high magnitude correction, there could be a stretch on the neurovascular structures. So there are various groups who have been using external fixator and a gradual correction method. So Koch group has used a unilateral fixator where pins are passed proximally distally, a single cut osteotomy cut is made, and then at the proper hinge area at the level of the osteotomy, a gradual correction is done. Some groups have also used Ilizarov for treatment of cubitus varus and valgus. An accurate placement of the hinge is very important at the level of the osteotomy so as to get an adequate desired correction over a period of time. And also, Herzenberg group has also been using the Taylor special frame for use of this external fixator in case of cubitus varus and valgus correction. So many osteotomies, so many types of fixation, and one wonders what is the best. So a recent study in Journal of Shoulder and Elbow Surgery was done to compare the internal fixation versus external fixation after corrective osteotomy in children with cubitus varus. And they found that both methods of fixation are reliable with a low rate of complications and satisfactory functional result. But they found that external fixation is more advantageous because it does not require an extensive preoperative planning, It has a shorter operative time because you're just putting the pins externally and making a single cut osteotomy. And they found they have lower cost and easier post-operative fixator removal. But of course, it comes with its own complications of pin tract infections and other acceptance of an external fixator by parents and the compliance with an external fixator. If you look at the literature, there are so many other osteotomies which have evolved from the time of French osteotomy. So there is this 3-dimensional osteotomy, double dome osteotomy, pentalateral osteotomy, each osteotomy prescription trying to match the elbow correction to as normal as possible. So what do you use? Of course, I would say that which works best in your hand, which is technically simpler and gives you a good desirable result with least amount of complications. So we have been using for cubitus varus a lateral closed wedge translation osteotomy with a good result. And for cubitus valgus, a Milch type of open wedge displacement osteotomy. So to summarize, cubitus varus and valgus are complex elbow deformities. You must understand that it's not just a cosmetic concern, but it also has functional problems. An ideal corrective osteotomy should be technically easy, effective, and stable. And my talk would be incomplete if I don't mention about the recent advances in 3-dimensional assessment of these deformities and use of these templates, 3D printed navigation templates in children with cubitus varus deformity, which can help you using them intra-op. And I think Taral has been doing this very regularly. And I invite Taral to share some ideas of his of using this 3D template technology for cubitus varus and valgus correction. Taral, are you there?
Yeah, I'm there. So I'll just share if you unshare your presentation. Quickly, I'm going to just in 2 to 3 slides, I'm going to show what we do. And as Binoti very rightly mentioned that it's a 3-dimensional deformity, and assessment and treatment also need to be 3-dimensional. And you have to do a lot of things. You have to translate, you have to rotate, you have to correct hyperextension. And to a simple orthopedic mind like ours, it becomes very difficult. So what we've been doing is developing these 3D printed jigs. So we do a 3D CT scan, and we make these customized jigs for patients, which has a distal end, a proximal end, and a slot to do the osteotomy. And these are made very much in India using software which is available here with help of some engineering companies. And this makes it very simple because all you have to do is pass the wires, do the osteotomy, and then align all the wires once the osteotomy is done, and your correction is achieved in all the 3 planes. The translation is achieved, the angulation is corrected, and even hyperextension is corrected. So this is in short what I do, fixed with an external fixator, of course. And this has given us good results. Probably in VIROC, we'll have a paper describing long-term results of this procedure. Thank you.
Thank you, sir. Thank you, Binoti madam. So that was a very innovative jig. And Binoti ma'am, thank you for the detailed biomechanics of the elbow and the consequences of not treating these deformities. It is a rarely discussed topic. We still have time, so I would like to take some questions from the audience. There are some questions. Ma'am, what magnitude would you say is a high magnitude for deformities around the elbow? At what point would you shift to external fixation and gradual correction? Is one of the questions. Binoti ma'am.
Yeah, so it depends again from, it also depends on the age, but if it is say more than 20 to 30 degrees or so, and if you feel that, acutely correcting causes a lot of stretch, and you will also find difficulty intra-op many times, getting that correction, angular correction or rotational correction. So if it's a very high magnitude, then you can always use external fixator. So, I mean, in literature, there's no particular figure which is mentioned, but you can make out clinically. And if they also have a 3-dimensional where it is not just a pure angular and you do require additional corrections. Many times once you derotate a little bit, see the varus is actually not, as I said, just one plane. It is a combination of varus with internal rotation with little hyperextension. So once you correct a little bit of derotate, then automatically the magnitude of actual varus reduces. So
Any technical tips for the sagittal plane as you're correcting the coronal
so
intraoperatively?
when you are taking the cuts, if you have a significant sagittal plane deformity, and if the child is older, where you're not expecting a spontaneous remodeling that is beyond 10 years of age, then your cuts, instead of parallel in the lateral view, you can have a oblique cut proximal, so that in effect it takes out a wedge shape, which is more in size anteriorly, which will automatically correct the hyperextension. So you can have not just parallel, but an oblique cuts on the sagittal plane.
There was a question for Dr. Swapnil, the role of Thomas splint in femur fractures.
I think in modern orthopedics and modern pediatric orthopedics, there is probably no role as of today for femur fractures in children. For transport and temporary immobilization till the time the child reaches the hospital, there is definitely a role. Anything beyond that can be managed for a child younger than 5 years with a hip spica and older than 5 years with some sort of a fixation device. Also depends upon the weight of the child. So no role.
Taral, sir, you raised your
I
raised my hand
add over
during
there.
COVID time. Yeah, Rujita, you first. Yeah.
No, exactly. Same thing that I was about to say.
Yeah. So during COVID times, a lot of our practices have been questioned. And when OTs were closed, anesthesia was not available. We had to offer this treatment to children less than 5 years age. Those who were whom we could not admit to the hospital, and we treated those with Thomas splint for 2 weeks. Followed by a single leg spica. Now, if you are to a child with a hip fracture, it requires anesthesia. And these things were just not possible that time. And we used Thomas's splints. In fact, Thomas's splints were not available then for some of the children. So almost 8 to 10 children we have treated, and I have discovered a new method now. A traction with Thomas's splint, send the child home, and after 2 weeks give a single leg spica. I would do that in children below 6 years as a method, preferential method for fracture shaft healing. Another point I wanted to make, Binoti, is it essential to treat cubitus virus? And I will not take names, but a very famous orthopedic trauma surgeon, who's also father of one of the faculties who is on this group today, has cubitus virus. I don't know if you all have noticed this. There is a famous pelvic surgeon from Calcutta who's a cricketer and also has cubitus virus, and he finds cubitus virus helpful to do acetabular reaming. And a very famous cochlear implant surgeon, the pioneer from Bombay, cubitus virus. And all these people are surgeons and living with cubitus virus. So again, question is, do you need to always correct this deformity? Is it cosmetic correction or a functional one? Binoti,
so that's what I said just in the beginning, because that is the general concern that it's mainly a cosmetic deformity. But that O'Driscoll work, which was done and published, has very nicely said, and Christine Ho also in recent article, that it's not just a cosmetic concern. They have shown tardy posterolateral elbow instability and in subtle way, problems of elbow arthritis and elbow instability. So maybe in this profession, it is serving as a boon. But if there is somebody who is a sports person or who requires, actual heavy duty work on the elbow, it is a problem. So that is why I said right in the beginning that it's not just a cosmesis, it is a functional problem. And there are a lot of things which have already been described and nicely shown. They have done studies on vectors and how the triceps mechanism acting on the medial size changes the whole of the elbow biomechanics. So I think you should go through that paper where they've nicely described that it's not just a cosmetic concern.
There was another question. When is arthrogram advised in joint injuries? If Taral sir could take this question.
Yeah, to me, acha. So I'll take for upper limb injuries. Maybe Swapnil can take for lower limb injuries. So most of the time we do it for elbow injuries, and one of the commonest indication for doing arthrogram is a lateral condyle fracture. This is to delineate the fragment. We also do it for fascial injuries of lower end of humerus and some very subtle radial neck fractures in a very young child. The only way to delineate it is by doing an arthrogram. So these are some of the indications mainly for elbow. We rarely do it in upper limb. Yes, so Swapnil, over to you.
Yeah, as regards the lower limb, now that we have good imaging modalities, at least in the city of Mumbai, to diagnose something, we don't really use an arthrogram, but during fixation, one is to see the adequacy of fixation, and second is to see very, very clearly, especially in complex ankle fractures or complex intra-articular knee fractures, if you've got adequacy of reduction after fixation, this is where I would use my arthrogram, at least around the hip, around the knee and the ankle.
Okay, thank you. There was another question. Any complications of allograft, any personal experience or tips you would like to share with the audience? Since you mentioned
allografts per se, no. Bone substitutes, people, at least the previous bone substitutes, a few people have reported, but these are mostly sterile reactions. They are not really infections per se. So it may be something like a graft rejection or something of that sort. So, but again, they've seen it mainly in the spine, but upper limbs and lower limbs, I'm not very sure, at least I haven't, but I'm pretty sure there are people here who are more experienced, so they can also share the experience as regards allografts and bone substitutes. Maybe Tharal sir, Binoti ma'am, Rujuta ma'am, if you've had any experience with infection.
The only thing only thing I would want to add is that if you're suspecting any pre-setting of in the slightest infection there, then you should use bone substitutes with caution. It's important to sanitize the area and make sure that you have a good recipient bed, and then use the bone substitutes. I had a question for Binoti myself. I mean, some of the slides that you have shown a fixator on the medial side. So, I mean, do you agree with the concept of the medial border fixator? I mean, don't you think it would be cumbersome for the patient and much more risk of neurovascular structures being encountered there?
I think the centers which are using them quite regularly. In fact, the Elisero and even Taylor Special frames. But I personally don't use external fixators. I always do one acute correction. But I think Tharal, who has been doing it, may be giving a better idea about it, whether he has found any such cases of neurovascular injury because of the fixator or the patient compliance with using an external fixator. Tharal?
No. So we always use it on from the lateral surface, the lateral area of lower humerus. It is, if you feel it's bony, there are hardly any muscle going through it. The medial is full of a lot of muscles, and medial external fixator is going to be cumbersome for three reasons. The ulnar nerve comes there. The second issue is that there are a lot of muscles over there. But as Rujuta rightly mentioned, you will poke against the chest, and it's not the most comfortable thing to do. So we have used the lateral external fixator, and I use it only for 4 weeks. Most of the time with percutaneous techniques, in 4 weeks the osteotomy heals, and that's the time we remove the fixator, just keeping across the osteotomy, and that transfixation wire is removed at 6 weeks. So we are not looking at a long fixator time in those areas.
Quick question for Tharal on the YouTube.
Thanks.
From Vivek Sodha and Suranjan
Nag. Question for Tharal sir. Sir, any role of ulnar nerve neurolysis in large cubitus varus corrections?
Yeah. So if it's a large cubitus varus correction, I use a shortening along with the dome, combination of shortening and dome. The only patient I remember in our series of cubitus varus which require ulnar nerve neurolysis is one which was already operated, had a lot of scar medially, and the ulnar nerve was stuck, and all soft tissues were stuck, which did not allow us correction. So actually I had to go down from a posterior approach, do a neurolysis of ulnar nerve, anteriorly transpose it, do a lot of soft tissue dissection, and then only we could achieve a correction of the varus. But for a routine cubitus varus surgery, ulnar nerve transposition is not needed.
Yes, so I think I would add that I agree with Taral that it is, if it's already pre-operatively you have ulnar nerve palsy symptoms, then during surgery it is advisable that you do an anterior transposition of the nerve. But otherwise, no. Even literature supports that.
We have time for one last question. There's a question for Taral, sir. In both bone forearm fractures, how long do you keep the plaster cast? Any difference in duration for green stick versus midshaft?
Okay, so again, these are the times for making treatment easier for the child and parents. So what I do is, whether it's a displaced fracture or a green stick fracture, my initial plaster is for 3 weeks. It is a above elbow plaster, and I convert it into a below elbow well molded plaster in the OPD at 3 weeks time. And this is our practice, whether it's a green stick fracture or a completely displaced fracture, which we are conservatively treating. Green stick fracture, in fact, contrary to what we heal than a complete forearm fracture. For a torus fracture of lower end of radius, we will just give a brace now. We don't even put them in plaster. So these are my sort of practices for the forearm fracture plaster. Over.
Okay. Thank you, sir. Thank you, ma'am. Thank you, all three. Very vibrant.
I think that was a very purposeful morning session, both on the hip and trauma, especially because it has attracted a lot of questions and generated a lot of discussion. Plus, we've been through what really has revolutionized the concept in pediatric orthopedics in the first 2 sessions itself. So before we move on to cold orthopedics, may I request Swapnil to do the BOS announcements, and we can take the screenshot before that.
Yeah, can I be heard now?
Yeah, it's
Excellent. So, dear viewers of the Bombay Orthopaedic Society and members as well, on behalf of the entire team of the Executive Council of the Bombay Orthopaedic Society, I thank you all for being patrons for this program, and I wish you a very happy new year. We have lots of announcements coming to us from the Bombay Orthopaedic Society. We all know that we had moved to physical conferences, and unfortunately, because of the COVID surge, we will probably move again to virtual meetings for some time. So the first virtual meeting and a big meeting coming for us is the Bombay Orthopaedic Society Day, or the BOS Foundation Day, which will be held on the 14th of January 2022. This is an online program on coming Friday between 8 p.m. and 9:20 p.m. The theme of this program is essentially about road victims and trauma safety and road safety. And we have a plethora of faculty from the Bombay Orthopaedic Society. In addition to somebody very, very special, Mr. Ranveer Singh, who will be our guest of honor for this particular program. So I request all the members and all the viewers to kindly watch this program, because this is something which we have planned for a very long time. Our Honorable Vice President, Dr. Rujuta Mehta, has planned it to very much in details, and I welcome all of you all for this particular program. Beyond this, we have our instructional courses, which will be continuing. We have the basic fracture fixation course between the 13th and the 15th of January. Please remember that all our courses are MMC accredited, and hence you can avail MMC points. And if you have any points remaining for your MMC renewal, you can always attend our courses, in addition to a lot of learning and a lot of understanding of the concepts of orthopedics. Next course again is the pelviacetabular course, which is an online course between 21st and 22nd January. Again, online, a very, very innovative course. This will be followed by the basic arthroscopy course, January 28th to 30th. Now, this essentially is going to be a physical course as of today at the Cooper Hospital. It's not an online course, but if there is any change, we'll let you know about it. We have the technology skills course coming in early February, on the 4th and the 5th of February. And this is essentially about people who want to update themselves with the latest technology as regards orthopedics and otherwise. We have the JESH, or the Joshi External Stabilization Systems course on the 17th and to the 20th of February for all the members, which will also be MMC accredited. The basic pediatric orthopedics course with the theme of operative pediatric orthopedics will be telecasted live for people who register for this course between the 9th and the 11th of February. And we'll have an entire plethora of pediatric orthopedic surgeons from across India. So please register and utilize this course to the maximum. The last course coming up is the basic Elizarov course between the 18th and the 19th of February. Again, an online course conducted by Dr. Milind Chaudhary. And this course is again something where you can revisit the concepts of Elizarov and deformity correction. The biggest event for this year is WIROC Global, March 2022, 25th to 27th of March. This is planned as a physical conference at the Renaissance Convention Center in Mumbai. This conference is going to be chaired by the Honorable BOS President, Dr. Sangeet Dawale, and two dynamic WIROC secretaries, Dr. Vishal Kundnani and Dr. Ashok Sham, are going to be at the helm of the proceedings. So I request all of you all to kindly send in your abstracts and register as early as possible for this conference, because we might have limited number of registrations depending upon the situation prevalent at that time. I welcome you all to WIROC, and I wish you a happy and a safe new year. Thank you very much.
Thank you so much. And thank you everyone for the lovely morning session. And I hope you all had time to quickly grab a cup of coffee. And now we are going to head to the third session of the Master Series today.
Jasna, before we do that, I would request Dr. Agnivesh to please play the video of the sponsors. Sun Pharma is the sponsor of this program, and Dr. Agnivesh, I request you to kindly play the video.
Yes, sir.
Is there no audio for this?
No, ma'am, there's no audio.
Okay.
Actually, there was an audio before, but it was taken from random, some random music, which was creating copyright issues.
Oh, I see. Oh, I see. So, in the meanwhile, we really thank the Sun Pharma for supporting BOS, and especially in a difficult time. And I think we should also be counter supporting them. On behalf of the BOS committee, I thank you all once again.
Thank you very much, Crosslands Life, division of Sun Pharma. And we can now move on to the program.
Yeah, so coming to the third session. So after the very interesting and captivating trauma session, we have a very difficult and kind of a session which is not very much liked by everyone, but we'll try to make it as wonderful as possible. So the next session is on cerebral palsy. And we are aware that there's no dearth of cases of CP all across the country and the world. And a lot has changed over these years. When we used alcohol and phenol to take care of spasticity and treat CP as like polio, a lot of principles have changed. And in the next 1 hour, Dr. Ratna, Dr. Atul Bhaskar sir and myself will take you through what has changed in CP. And I invite Dr. Ratna Maheshwari to talk about injection botulinum toxin and its status today. Over to you, Ratna.
Thank you, Jasna. So, good afternoon, senior colleagues and friends. My role today would be to tell you about botulinum toxin as it stands today in cerebral palsy. What we do know about children in cerebral palsy is that the natural history of gait and movement is one of deterioration. The cause is a rising muscle tone. This is from the Swedish registry, which suggests that spasticity peaks between the ages of 3 and 5. From the rising tone, develop the lever arm dysfunction and other deformities, and there's a decrease of muscle force over time. So botulinum toxin is a tool for managing spasticity in the younger age group and a tool for delaying surgical intervention for these children. And it has been used since the early 2000s for the same purpose. This is the effect of contracture formation, which we wish to avoid in these children. So what is Botox? Botulinum toxin comes from Clostridium botulinum. There are 7 serotypes, of which serotype A is the most commonly used. In serotype A, there's Botox, Dysport, and Xeomin. There's a large literature backing for Botox and Dysport. The difference between the three is in the protein constitution and the excipients. The maximum dosage, safe dosage for Botox is 16 to 20 units per kg, same for Xeomin, and for Dysport, it's 30 units per kg. We don't know how botulinum toxin works. It's local, temporary, partial chemodenervation, and it lies in the focal and reversible range of the spasticity compass. Although there are some questions which have been raised about the reversibility of Botox, and I will address the same later. But the central question is spasticity an indication for using botulinum? The answer could be yes, no, or maybe. It depends on the case scenario. So now, how do we do botulinum? An optimal injection technique is crucial to the success for treatment with botulinum toxins. An optimal injection means the injection is at the motor end plate zone, which is distal to the arborization of the motor nerve. And this particular article discusses the localization of the motor end plate zones in human skeletal muscles. And they've diagrammatically described the same, and I encourage you to see. Botulinum toxin can diffuse up to 4.5 centimeters of muscle length from the point of injection. The technique, the manual technique, is inserting the needle and checking for the reciprocal movement as we move the leg. Practically, it looks something like this. This is a rectus femoris injection, and they're checking for the reciprocal movement. The accuracy with manual techniques is reported somewhere around 50 to 80% for the larger muscle groups and less so for the smaller muscle groups. Especially for the upper limb, we can use electrical stimulation. We can use ultrasound guidance for the deeper muscles, as is shown here for the tibialis posterior. Post-Botox, it's really important to synergize with plasters, orthosis, and targeted motor training. Intensive therapy is very useful for training new patterns and to improve the agonist-antagonist balance. As far as repeat injection goes, we do not know, but there are some studies which suggest that there is more improvement in the gross motor function measure and walking parameters after the first or the first 2 injections. But practically, it depends upon the response with the previous Botox injection, and a critical documentation of strength is essential for any repeat injection. There was a study which compared 4 monthly injection protocol to an annual protocol over a period of 3 years, and it noted no significant difference in the outcomes in either of the 2 protocols. There are some more poor responders to botulinum toxin, and that's usually due to antibody formation to the brand of botulinum, and they may respond to another brand of botulinum. Once we know how to use it, the more important thing is when to use it and when not to use it. Not all spasticity requires treatment, so we use botulinum in relation to the child's motor milestone, in relation to therapy, in relation to surgery, and there are some basic premises which we cover when using botulinum toxin. When there's a failure to gain milestone because of spasticity, that is, the spasticity is interfering with the function of the child, then that is a good indication for botulinum toxin. The rationale being that spasticity causes contractures, which causes mechanical malalignment, difficulty in standing, walking, and failure to gain milestones. It can be used in relation to therapy when the child has plateaued on conventional treatment and there is a problem in spite of increasing therapy and difficulty with splint use, or there is impractical intensity or duration of therapy to maintain function. It can be used as a tool to delay surgery, to assess preoperatively, what exactly needs to be done in terms of surgical intervention, it can be used in combination with surgery or post-surgical relapses. The basic premise for botulinum toxin still remains dynamic spasticity and the possibility of restoring agonist-antagonist balance. We use the Tardieu scale to judge dynamic spasticity, where R1 is the fast catch and R2 is the slow stretch. If this difference is wide, then that presents an excellent window of opportunity to use botulinum toxin. But if the difference between the two is not much, that means it's moving towards a fixed deformity and will not respond to botulinum toxin. Spasticity causes a weakness of the agonist and causes a loss of agonist function. So with spasticity reduction, what we're trying to do is increase the use of the agonist, increase the cortical representation, which can help with neuroplasticity and reinforcement of correct patterns. Now we come to some case scenarios to how the patient benefits. Often we get children with equinus. In a child, especially with hemi or diplegic cerebral palsy, this equinus causes problems with positioning balance. Because of the very strong plantar flexion knee extension couple, there's a recurvatum which is happening at the knee. This causes implications in gait and splint use. The target muscles are often gastro, but here we do need to check for rectus, because if we don't address that, there will still be problems with clearance and swing phase. And we do need to check for the hamstring, because doing a gastro injection without addressing the hamstring can result in the child walking, which may unmask the spasticity of the hamstring and can result into the child walking with bent knees. So this is a left hemiplegic cerebral palsy. We can see a 4-foot contact pattern with a knee recurvatum and causing issues with the way the child walks and balance. This is him after gastroc injection 3 years later, and there's a more normalized heel-toe gait pattern. The knee position is better. And this is the agonist-antagonist balance after 3 years of the botulinum toxin injection. And this is him after 8 years, still maintaining the heel-toe walking pattern in split. So what does literature tell us about botulinum toxin in a child with equinus? The problem with interpreting literature as far as botulinum toxin goes is that studies are uncontrolled. There's a smaller duration of follow-up, and usually it's reported on 1 injection cycle. Botulinum toxin has a strong evidence to reduce spasticity and a moderate evidence to improve gait, with the most clinically significant improvements seen under the age of 4 years and moderate responses between the age of 4 and 6 years. Coming to a scenario with the knee, usually children come with tight hamstrings, which causes problem with the sitting balance because there's a sacral sitting, there's a flex knee in gait, or it could be a jump or a crouch gait. So functional implications are sacral sitting, energy inefficient gait, collapse with high energy consumption and torsional issues. The target muscles here are usually medial hamstrings, hip adductor, gastrosoleus for a jump gait, and hip flexors. This is an image of sacral sitting because of tight hamstrings. And we look at this child who's walking with a jump gait and was given a botulinum injection to the hams, to the gastroc, and to the rectus with a better heel-toe walking pattern, better control of the knee, and a slight improvement in the swing phase of clearance. Another scenario which comes up with the knee is a stiff knee gait because of rectus spasticity. It could be post-surgery, or it could be that the hams have been buttocks and we've missed the rectus, and which causes a problem with bending the knee in swing. So the target muscles here are again rectus femoris and gastrosoleus, but always before injecting the rectus, we need to check the muscle power of the hamstring in order to not cause further problems in the child. With regards to the hip, often tight hip adductors and scissoring is an issue which causes deformities, torsional issues, hip instability, and the target muscles are usually hip adductors and hamstring. Often in the with issues to the hip, there are 3 muscles which participate in the force couples: the adductor, hamstring, and the hip flexor. Another scenario with the hip would be an increase in the pelvic inclination and rotational issues with implications in the gait, deformity, torsion. The target muscles here are hip flexors, adductors, and hamstring, but always check the gastrosoleus, because if we do not address that, the child will go back into an anterior pelvic tilt. Now, this usually it's a single event multi-level Botox. It could be compared to a medical rhizotomy, where there's simultaneous injection of hip flexors, hamstring, and gastrosoleus to normalize stance and gait. For example, this child here, and post multi-level Botox, a better stance balance for the child. This is based on the interaction between hip, knee, and ankle. And this produces an overall better response than a single level injection. What are the contraindications of botulinum toxin? It's a severe fixed deformity where there's weakness of the antagonist, or there's a mild spasticity which is compatible with function, or athetosis, a generalized dystonia, or when the goals are not defined. Use botulinum with caution when there's lack of motivation or cognitive impairment, poor compliance to therapy or splints, poor family support, neglect of the extremity or sensory impairments. Coming to what literature tells us about botulinum toxins, since the early 1994s, there have been positive reports for botulinum toxin as far as tone reduction, improvement in the joint range of motion, and gait. We do know that botulinum toxin causes an objective decrease in the modified Ashworth scale by 1, which lasts for between 3 to 6 months. So this translates into an improved range of motion and a measurable improvement in gait. But this is at the level of the body structure and function. The problem is that we do not know what happens in the domains of activities and participation. There are fewer studies with robust methodology to interpret data as such. There's very little known, in fact, about the long-term effects of botulinum toxin. And it's very, very difficult to isolate the effect of botulinum toxin from that of other interventions like casting and therapy, which often go in conjunction. Adverse reactions to botulinum toxin have been described with high doses, especially in GMFCS 4s and 5s. And it's probably the harm caused is more than the benefits in the GMFCS 4 or 5 are the most severely involved children. As far as botulinum and hip displacement goes, there was this randomized control trial from Graham and group at the Royal Children's, which compared adductor and hamstring 6-monthly injection with brace with a control group which received no such intervention. And they noted that progressive hip displacement continues to occur in spite of the botulinum injection. There's been a lot of focus on the management of spasticity over the last 2 decades, and that means that we have possibly ignored the negative features of upper motor neuron syndromes like muscle weakness and tendency to fatigue, and probably they need to be discussed more often. Also, the concern of muscle atrophy, which is noted in cosmetic applications with botulinum toxin. There's a traditional view of botulinum toxin wherein we say that the muscle completely recovers in 6 months, and there's a current view which notes that there's possibly a partial recovery at 12 months following botulinum toxin injection. However, what we don't know is that, is this muscle atrophy any different from that which is going to result from plaster immobilization? Or is it the natural history of sarcopenia which happens in these children with cerebral palsy, or is it a probable disuse atrophy? We do not know these answers, and we await further research for knowing the long-term effects and reversibility of muscle atrophy with botulinum toxin. The future directions are to use botulinum after due thought, caution for GMFCS 4 and 5, low dosing and a larger interval between the injection, identify the target muscles and the spasticity which is secondary to those target muscles, and inject those muscles only. Always, we have to think of balance between the joints when we are doing these interventions. We have to plan strategically. And a last note on botulinum toxin and contracture formation, because I feel that this is really opening up a new perspective and causing, and may have the potential to cause practice changes in the future in this field. What we are coming to learn is that spasticity as such is a very narrow viewpoint when it comes to contracture formation. And there's a large iceberg below, which we are just coming to learn about. Recent studies at the level of molecular biology and histopathology suggest that, in fact, the contractile elements of these children are elastic. The sarcomeres are long and overstretched. The sarcomere titin is less. And what the actual issue may be is that there is a high extracellular matrix, collagen type 1, which is maybe responsible for the stiffness and contracture formation in these children. There is an epigenetic view which is forming, where there is problems with the DNA methylation, decrease in the satellite cell number and function, increase in connective tissue and fat, and ribosomal dysfunction. So there are a lot more variables for contracture formation apart from spasticity, and this field is just opening up, and we will learn a lot more in the coming years. Thank you so much for your time.
Thank you, Ratna. Yeah, thank you so much. And now to the next talk. So just a second, I have to share my screen. From spasticity management in cerebral palsy, what Ratna mentioned, I'll be talking more about the locomotion or the walking scenario and what has changed over the past years in terms of gait analysis. So we all are very much interested in looking at how the patient walks when they enter our OPD or preoperatively also. And not only in general, we are interested in how people walk or check out their walking pattern. The analysis as such came into vogue from World War II times. And the first time the analysis was done to analyze more of animals rather than human beings. And later, post the World War, the amputees were the ones which were first time analyzed for the use of orthosis and to improve their walking pattern and other problems. And eventually, Dr. Perry and others came into picture and they started analyzing the children and adults with cerebral palsy. Now, I would like to mention, of course, about the father of motion analysis, Professor Jim Gage, who came up with the first paper on gait analysis in 1993. And ever since then, how has gait analysis changed? In 1993, he mentioned then that the result of gait analysis has changed the management of CP dramatically. If it changed then what has happened from then till now is like what I'll be talking about. And these are two scenarios. So we look at a child walking in the clinic or in the ward and analyze their walking pattern. And this is how a gait lab or gait analysis would look like, and the amount of information it gives in terms of having...
Sorry to interrupt. I think your presentation is not visible.
Yeah.
Going ahead, I think you need to reshare.
Just a second. Okay, thanks for telling me that because I was on the 4th slide already. Now?
Yes, yes.
Yeah.
Yeah, that's fine.
Okay. So just coming back to one slide, like I said that in 1993, Professor Jim Gage mentioned that the gait has changed the scenario dramatically. And what was that dramatic change is what we see here. This is the child who is walking in the ward, and we try to analyze the walking pattern of the child. And this is another child we see walking in a gait lab. And we get a whole lot of more and much more information in terms of joint movement, joint power, and many more temporospatial parameters, which are very difficult to get here. So yes, there has been a dramatic change. And how did that change occur over this time? And what has changed in the treatment? So way back in 1987, they came up with the classification, which was the Winter Gage and Hicks classification. And it broadly classified the gait patterns on the sagittal plane. And these patterns, what they, Winters and Gage, identified that there were many options which were non-classifiable, and hence more better classifications came, which gave us a treatment algorithm. And ever since that, we have always been following this sagittal gait pattern and these treatment model, which came up with it. But here we are just looking at the patient in a sagittal pattern, and we don't treat them in terms of coronal or transverse plane problems. And these management algorithms didn't help us when we wanted to treat the other plane problems. And that's how, for craving for more information, the gait lab helps us to pick up much more problems and much more subtle impairments as well. If we look at these two children, they both have hemiplegic CP, and the subtle changes here versus the obvious changes here. So both are very well documented as well as picked up, and a lot of other information is acquired by getting a gait analysis done, and a much more better treatment plan can be devised based on this. Also, pre-op analysis of severe deformities helps us to get a very good dosage of surgery. Unlike in the past, what we mentioned that we need to do a birthday syndrome or simple tenotomies or tendon lengthenings, now we define this as a dosage of surgery, and it doesn't fit for all the entire CP population, but it is based, targeted to each patient, and that's how it is called dosage of surgery. And most importantly, I would say that gait analysis is very important when the clinical findings don't match with the walking pattern. That is, the static evaluation is not going in hand with the dynamic walking pattern. So we see this child walk with a mild crouch and the knees being flexed. But when I evaluate the child, there is no knee FFD. So then here is the question, should we lengthen the hamstring? Should we Botox the hamstring? Should we just give a stretch plaster? Should the child continue in therapy? And all these questions get answered when we go into the detailed nitty-gritties of the gait analysis. And hence we come up with a very much better plan, which will help the child come up with optimum results. So just by doing a gait analysis, it doesn't mean that you get a ready prescription of what needs to be done. It is not a ready-made prescription, and it needs to be supplemented with a lot of data. Like I said previously, a static evaluation is very important. So the physical exam is very important. If you look at this child, he has a severe crouch. And when I look at him he was the child which I showed in the previous slide when we looked at him at sagittally. And when you look at him in front, there are a lot of rotational problems and a malalignment where the femur is being turned inward, the tibia is going in external torsion, the feet are in severe planovalgoid. So all these problems, they need to be seen from different planes and correlate with the physical exam, as well as the radiological study, that is 3D, the rotational profile and the gait kinematics. And with all this, we get a detailed evaluation of what actually needs to be done. And if we label down the impairments, we can come up with a very good solution. So this child, I put down the physical findings, which I feel are the impairments here, the radiological findings, and did a femoral extension osteotomy, patellar tendon advancement, and in the second stage, a supramalleolar tibial derotation osteotomy. If you look at this child, previously is walking with a cane, and we label him as GMFCS3. And now if we look at him post-operatively, the same child, and you will notice that he still continues to walk with a cane. So functionally, we always used GMFCS to see our results or outcomes. And all the surgical outcomes prior to gait analysis or without a gait analysis lab grossly depend on the outcome in terms of GMFCS. Our whole motto is to change a child from GMFCS 2 to 3. That is, change one level in GMFCS. But now if we look at this child, we see that his gait pattern has improved immensely. He walks much more upright. It is a less energy consuming gait, but still he continues to walk with a cane. So he remains GMFCS 3 to 3 only. So what and how do I quantify, or how do I measure what change has happened? So actually, if we see broadly, the gait as the functional level didn't change much. So here the gait analysis comes into the picture. And before this, we would quantify the gait patterns as better, good, and walking differently. So looking at this, we would say, yes, the child is doing good. He's walking better. He's much more good. The energy consumption is late. But how to quantify? And this is where the indices which help us to quantify the change post our surgery and quantify our outcomes. So there are various indices which come up from the gait analysis, and they help us to quantify what change has happened post-surgery. And that's how studies or research in cerebral palsy can make a difference with the help of gait analysis. So there has been a lot of clinical relevance of gait analysis ever since it is introduced. And it has led to, so if you look at some of these papers, there are decrease in number of surgeries, or there is an addition in number of surgeries which were performed. A very wonderful recent paper from Canada, which comes from Dr. Unni, he said that there is a lot of reluctance amongst our own colleagues to use this modality. Yes, because it's a complex tool, it's an expensive tool, it's a time-consuming tool. But let's look at the brighter side. It helps us in making a better decision. It helps us to do the right and correct interventions. And yes, this is the best time to collect these data and create cohort studies or clinical trials and create evidence for how and why are we treating these kids and what is the outcome post the surgeries or the interventions which these kids are undergoing. So way back, there was this wonderful editorial, which when we talk about reluctance, I would like to mention this, that this is like exactly the way taking an expensive car to a garage and getting it analyzed rather than taking it to some place where there is no proper analysis. So a person would correlate with this, and while we would not take the car to analysis in a very regular place. But yes, this is what people are actually looking for. They want the right analysis, they want the right diagnostic, and they want the right treatment out of it. So what changed over a period of time? Like I mentioned, a lot of surgeries, they changed. And this was a wonderful paper from Heidelberg, which came around 10 years back, which changed the role of transfers of rectus to just simple lengthening of rectus. And post that, there have been various other labs and other centers which have created the same results. And now instead of doing the cumbersome rectus transfers, we have shifted to more better and minimal invasive and lesser time to rehab kind of surgeries like the rectus, distal rectus lengthening. And apart from this, like I mentioned, the whole scenario or the dosage of surgery totally changed. What we learned previously, the birthday syndrome, that the child, if you remember, there were pictures where the child every year celebrates the birthday in the hospital by doing one surgery at each time. First, it was the gastro, then the hamstring, then the hip. And then came the newer terminology, that is the SEMELS, or the single event multi-level surgery. And now with all the advanced, more information, what we have come out is dosage of surgery, and additionally change in different surgeries. So like previously, we used to always lengthen the iliopsoas. With the advent of gait analysis, it changed totally. So this is how force plate and kinetics are captured. And this helps us to analyze if we really need to change the hip flexion deformity. Is it compensatory or is it a real flexion contracture, and then only treat it? And a lot has changed over the years, from doing surgeries like release at all 3-4 levels, like the psoas, adductors, hamstring, and gastro. Instead, we shifted to more of like guarded lengthenings, transfers, and more of zonal lengthenings, which are based on the gait analysis. And now with the more better dosage of surgery, bony surgeries are combined with soft tissue surgeries to give best outcome and treat the liver arm problems. So yes, it did make a lot of alterations in surgical decision making. If you look at this paper, they observed a lot of inappropriate, which they mentioned that it is important that we don't do inappropriate surgical decision making. And it was most likely without gait analysis. And they said that they had a lot of surgical recommendations, which were observed in each of these muscles. And there are many more other papers which also talk about better decision making and good outcomes post doing a gait analysis in child for treating with cerebral palsy and its problems. And when it comes to an additional tool which comes with the gait analysis, that is the EMG. So yes, many a times if we look at a child who's walking with equinovarus deformity, and we don't know that if it's a tibialis anterior involved or the tibialis posterior, should we lengthen one of it or should we transfer one of it? And then comes the role of the EMG and the walking analysis. And it very well helps us to understand that which muscles are not working in their proper phase. So if there's a phase prolongation, or does it need lengthening, or if there is a phase reversal, then it needs a transfer. Because already these muscles are spastic, these muscles are weak. So they have their own weak power as well as an abnormal tone, and transferring can cause completely opposite deformities. So yes, analyzing the exact surgery or the procedure can be a very much boon with the analysis again. So looking at all the bright side or all the positive points, I would like to come to the cons of the gait analysis. That it's not that it's just a very shiny and a wonderful tool to pick up things. There are errors possible with the gait analysis and the lab as well. So there could be ghost markers in younger children with less than 100 centimeters height. It is difficult to analyze their gait. There could be problems if there are low resolution cameras or if there's an outdated software. So just like a mobile or any other software we use, the lab also needs an upgrade or an updation very regularly. So to quickly summarize, I would say that the lab has certainly changed a lot of things in terms of pre, post, and of course it comes with some of the limitations as well. Yes, it's a great tool, like I mentioned, that we should not be reluctant in using it. and it picks up not only subtle but also complex problem. And let's look at it that it's not a prescription, but yes, we are always here to let you know that what best can be offered to your child or the patient in terms of dosage of surgery, and then we could correlate it with the static or radiological findings. Post-operatively, it helps us to quantify the outcome and not just call it good, better, bad, or different, but get a number. So the indices actually give us number in terms of 100 or percentage or a ratio or a score. And that's how we could quantify that. And that can be used for research as well as documentation. And like I mentioned, some of the limitations in the previous slides, I have also kind of just enumerated them here. And so not all the kids need gait analysis. There is a particular subset which should actually 100% go for the gait analysis to get very good outcome. And it is important that we understand what are those patients. So we can't do gait analysis in children who don't walk. So just because somebody thinks the child is not walking and he needs to walk, we can't do a gait analysis. And that can be a limitation in a way. But we need to understand this fact that it is only done in walking children, GMFCS 1, 2, 3, that is who walk with walker or crutches, that is the GMFCS 3. So this is and gives a supplementary data and an additional data for better outcomes. And like I mentioned, it's a very good tool when our clinical findings don't match with the dynamic walking pattern and when there are combination of gait patterns. So what we saw, the classifications, they are very broadly classified, but not every child fits into the classification like a type 2 hemiplegic or a crouch or this, because there are hidden other problems, muscles firing in different planes, children who have been treated previously somewhere and iatrogenic problems have been caused because of improper T-knot-knees or procedures which are not indicated. All those complex patterns don't fit into that 2D gait pattern or the sagittal gait pattern. And in that case, the gait analysis surely adds more information. And pelvic tilts or the proximal body posture, which is not explanatory with the distal problems, here also gait analysis gives a very good information. So to conclude, I would say that, yeah, it's a wonderful tool and this is not the end of it. If we look at it, the future of gait analysis is much more brighter. Now we are confined to a single lab and to some limited limitations or indications. But in future, the lab could be markerless, like we look here. It could be in any setup to analyze any sports problems, improve the sports efficiency, and also the body postures. And we could get it done wherever we want and not remain confined to a particular lab. So this was all about the changing scenario in gait analysis. Thank you. So next, yeah. Sorry.
Excellent talks, both Ratna and Chasnal. I think you all have done full justice as conveners, in-depth analysis, and absolutely on point, learnings from both your talks. Now we move ahead with Dr. Atul Bhaskar telling us about decision-making in cerebral palsy, and then let's take questions at the end of the entire session.
Thank you, Rujita. Chasnal and Ratna have really covered the gist of cerebral palsy. And I think what I'm going to do is just cover some aspects of treatment in the older children where, as Chasnal mentioned, we cannot use gait analysis all the time because of the severe contractures. So everyone can see the screen?
Yes, sir, go ahead.
Screen is visible?
Yes, sir, it's perfect.
Yeah, okay. So I'm talking about a subset of children which present during adolescence. And if you really look at the burden of CP in this country is huge. And unfortunately, many of these children with special needs, the parents or the child themselves are illiterate. And as a result, they go from pillar to post seeking various kinds of treatment, with limited resources. So this was a mother who brought these two daughters to me. They were twins at birth, and one of them had the potential to walk, but unfortunately had not received any treatment other than stem cells, and they were confined to the wheelchair. So these are the issues and challenges which we face in the older children when they present to us. And we all know that what happens when these children remain untreated. This is the medical aspect. what happens to the social aspect? Is the burden of care on the mother and the parents. And I've seen many times these heavy children have to be carried around, although they may have some potential to, at least ambulate with support. So these are the challenges which come to us, especially in the older CP children or the ones which are severely involved, but not had adequate assessment. Now we know that even the level 4, ones can have some improvement in the functional mobility scale. They may not change in the GMFCS scale, but orthopedic surgery does make a difference in some of these children where they can improve in the FMS scale to some extent. So I think that is where this real challenge comes in, how to identify these children on how to, give the prescription for surgery. Now, all of them have been to the journey, which already Ratna and Chasna have covered. So they've had multiple surgeries. Some of them have Botoxes. Some of them may have probably had no treatment. And by the time they come to us during adolescence, they have exhausted most of their means and become a huge challenge in treating them. So muscle weakness is a huge challenge in this population. So weight gain, rigid contractures, poor muscle power, financial burden, logistics, and rehabilitation. All these, really pose questions to us whether these children can be easily treated in a setting which can improve the child's function. So we came out with a simple scoring system, which is called the FAST score, looking at the feasibility of ambulation in some of these children which are very tight by doing contracture reduction surgery. So a quick assessment involves a child able to stand on his knees for at least up to a minute. Good power in the upper limbs, anti-gravity power. That means they can lift the elbow and the shoulder so that they can at least hold a crutch or a walker. Selective motor or voluntary control, looking at cognition, and the adductor thrust and scissoring. And I think this is an important part which I'll discuss and touch upon. So children who have a score of 4, that means they can fulfill all these criteria, act as a good screening tool to further assess them, with the detailed examination, and then offer them some kind of contracture reduction surgery to improve the ambulation. So there are 2 types of children. The one, again, I feel we need to assess their tone. Now this is very, very subjective, and borrowing a chapter from Demiglio's score, some of the children can be stiff, spastic. That means they may have some contracture, and part of the stiffness is also the strength. So here, these children tend to do better than the ones where they're stiff, but they're also hypertonic, like this girl who underwent hamstring surgery and had a severe pelvic obliquity, or like this girl who was very, very hypertonic. And under examination, she had full range of movement, but while walking, had gross muscle weakness, and like this girl as well. So these are the ones which are low tone, and you try and do surgeries in them, it won't be successful. So hence why this tone assessment also becomes important before you attempt any surgery. But we have to still do a proper static assessment, look at the FMS scale, do a gait lab if it's possible in some of the children, and also do X-rays. So you must go to the diagnostic matrix and not just base your decision on the simple score. I've got 2 children here of different types. This is a dystonic child, and this one is a stiff, spastic child. I'll just see if the video works. So here he's you can see he's ambulating with both his hips and knee flexed, varus foot, and this child has got a dystonic CP. But both these children fulfill the criteria for surgery, and they underwent multi-level releases with osteotomies. And here he's post-op, and here trying to walk without support. So it's not that we've done anything heroic. It's just that we've connected the lever arms, got him into a better posture, and he already had the muscle strength to power himself. And here he's doing what he was supposed to do earlier on, but unfortunately because of contractures, he could not do it. Similarly, this child underwent bilateral distal femoral extension osteotomies, patellar tendon plication, and foot surgeries. And here he's post-op. We put them in a long leg brace for 6 weeks, and usually they commence walking. This is a 6-month video. I don't know whether it works. This is the long-term video where he comes at 2 years. He has got a job now in a coffee shop, and he is able to ambulate without support. So potentially these children had the ability to walk. It was just that the muscle strength was masked by the contractures, and all it did was undo the tightness, which helped them get better. Of course, all children don't do as well. When you have a score of around 2, where this child had poor selective motor control and is adductor thrust, when they have this kind of thrust, it's very difficult for them to walk independently because they cannot balance the coronal plane, and hence this child he's dependent on a forearm crutch. He's able to walk, doesn't need any carrying by his parents. So at least we're able to achieve a level that he's able to walk with his father staying behind, so it doesn't trip outside on a rough surface. So sometimes we can still improve the FMS grade or the distance of walking. This is a child with a score of 3. He had severe adductor thrusting, and I'll demonstrate this. And these children have almost impossible to stand on a single leg, without support. And that's why the coronal plane assessment is very important in these children. So this child, we did his lever arm surgery. Unfortunately, he still walked like this, and he was very, very dissatisfied. And because we could not improve his pattern of gait. And this adductor thrust, despite doing a derotation osteotomy, persisted because of the severe pull of the adductors. Now, what is the outcome of these surgeries? Now, Bruno had given a paper on level of results of single level surgery. I call it the final event surgery because after this surgery, many of them will not return back for further surgery. So this is a final event surgery. You should try and do your best in terms of assessment and in what one can achieve by doing lever arm correction. So they seem to maintain the FMS grade, and the improvement is seen because the muscle power is unmasked after the contracture correction. So we have this data over the last 8 years where we've seen 34 patients in this group. They have various contractures, foot deformities, and we looked at the FMS grade. This was the FAST score of these children. And you see most of them were in the mobility scale of less than between 5 meters to 50 meters. And 2 of them just barely walked less than 5 meters. And these children were subjected to this kind of, I call it final event multi-level correction, where you try and correct the joint deformities, the muscle recessions, the foot corrections, either in one sitting or in staged procedures, but try and get them as straight and braceable so that they can improve the function. And this was the result at 2 years, where we found the children who had a better score improved in the FMS grade. They stayed in the same GMFS grade, but the mobility score increased to more than 50 meters. That means they could walk in the community, they could walk around the household, and there was a change in at least 75%. So 27 of 34 children had marked improvement following this kind of multi-level surgery. Surgery is not rocket science. It is very straightforward. There are very few surgeries which are done, but the key thing is to determine what factors are involved in improving the child. So one has to understand the neurobiology, the muscle strength, the muscle power before subjecting them to this kind of big surgeries. Get the feet, as long as the feet are braceable and straight, you put them in early bracing, don't put them in plasters for too long to prevent muscle atrophy, and get them walking early with the brace. And that really helps in improving the muscle power very, very early on. Couple of examples. This was a girl who was walker dependent, and you can see her gait. She had undergone previous surgeries, and here she is at 1 year, really able to walk without support and also in the community. And that's been a remarkable change in her following this kind of multi-level surgery. Another child who had just recently done a surgery, he was almost in very severe crouch, had undergone previous Botox injection, a lot of calf atrophy. But you see the adductor thrust. This is a real challenge. So this child, one has to be very guarded in terms of what they can walk. He's just come out of his plasters now in a brace, and we attending now physiotherapy. But this child, I don't think he'll be able to walk independently. He may use some kind of support or a cane or a walker because of this marked abductor weakness. Just a couple of other children. This is a child with a score of 3. But this child over the years had no splintage and no physiotherapy, picked up height, and he really deteriorated in the last 2 years. And I just feel that if they don't get this adequate therapy or they get splints, they tend to get worse with time. And I think that is a real challenge when we do this surgery slightly early. This was a child who was a score of 4, very good cognitively, but complains about lurch. So despite a good correction, he's not happy. He feels I'm still walking with this kind of pattern, and my friends are teasing me. Now, I think that again, counseling is very important. One must tell them they will never become normal, although the expectations are, after this kind of surgery remains that they would walk normally. So one must counsel them adequately that some amount of weakness will remain, especially in the coronal plane. And there have been a number of papers. I think the best paper came out of Manipal, where looked at the results of this crouch gate surgery. They did stage surgeries and they found that the mobility score increased in all the children by correcting their deformities. And even if the fractures, the sleeve fractures, which come because of the pressure on the patellar tendon, improve with time. So I think this is what kind of motivated us to do this kind of multi-level surgeries in the severe adolescent CPs. And there was a paper from Heidelberg again, looking at surgeries in adults, which we've not performed. And the mean age here was 26.1 years. And they needed more bony surgeries, more rotation osteotomies because of the contractures. And gait improvement takes almost a year, more than a year. And that must again be counseled to the parents. The child may not improve immediately. It takes up to a year for them to improve. And finally, I would invite everyone to use our new lab at the Xavier College of Engineering. We've got now the latest cameras and the force plate. And I welcome each one of you to visit the lab at some point. And we'll be happy to, collaborate with some projects. And like Chasnal said, I think that is the future of treatment of cerebral palsy. Thank you very much.
Yeah, thank you, sir. And that was wonderful. So we have one question for Ratna. Role of botulinum toxin in dystonics.
Yes, as far as dystonia goes, botulinum toxin can be used for the more focal variety of dystonia. But dystonia as such varies in its severity over a period of time, and it needs to be thoroughly assessed. And still the motor outcomes are unpredictable, but it can be a good tool for pain management or positioning.
Super. Yeah, so I think we are short of time. We're already running 5 minutes late. And so over to you, Ratna, to conduct the next session.
So the next session, we move on to Clubfoot. And I invite Dr. Rujita Mehta to now speak on how Ponseti has changed Clubfoot practice.
Yeah, so thank you, Ratna Chasnal, for really sticking to time. I hope the screen and audio are now all in sync.
Yes, ma'am.
Okay, so very few subjects have really witnessed a huge shift like the way Clubfoot did. And the one man or the one technique which really brought this about was Dr. Ignacio Ponseti. And I'd like to start with this famous saying from him that your child is perfect, we only have to straighten his little feet. So coming from the master, when he simplifies something, we have to read in between the lines and realize that this is actually oversimplified. But the beauty of this technique is in the kind of biomechanics it has pursued and the way it has made the corrections for club feet so simple and in depth. So we'll take a look at what this is, how it has changed, and we'll look at within Ponseti also how much has changed and where all now it can be applied. So all of us know really that the classical idiopathic club feet comes in neonate in very, very assorted sizes, shapes, and a lot of varieties. So if you take a look at here, Ponseti technique, you must remember, is described for the classical idiopathic clubfoot of the neonate, was not really described for all these syndromic associations. And the spectrum in India, as compared to other countries, is ranging from various neglected, which is a misnomer now, it's a wrong term to use, various walking age or untreated club feet so far. And within that too, there are varying degrees of severity. As you can see, this Escobar syndrome, a walking age supple clubfoot versus a neurological walking age clubfoot. So each one is going to behave differently and is going to require a different way of applying the Ponseti as well. So is really Ponseti something new? Was it some eureka moment that happened? Not really. There have been a lot of plastering techniques which have been described. For example, Kite's method was very much in vogue. But what was the difference is that it used to involve a lot of stretching of Achilles tendon or all the structures all together. They used no braces post-op. They took multiple plasters, means it was an average of 25 weeks of treatment almost. And the most important difference is where the finger was placed, as you can see out here. This was really almost on the calcaneocuboid joint. And what Dr. Ponseti really did is by studying and understanding the pathological anatomy of the clubfoot and realizing that the apex of the clubfoot deformity is here at the head of the talus, which is completely out of the ankle mortise, and shifting the pressure point here, creating a pivot, very gentle manipulation of the multi-segmented complex anatomy that is the foot. By manipulating one segment, he gradually created a shift or an uncoupling of the other segments. So the bones, ligaments, everything started moving and gave a beautiful gradual correction, very much similar to a sculptor molding his thing. And why is it considered a landmark technique? Because these were some of the papers which you could go through. This was really what changed and made the world sit up and take notice that even on a huge 30-year-old follow-up, lots of his patients were having great results in terms of good and excellent outcome where pain and function was concerned. And in the no clubfoot group, it was almost 85%. So the foot scores in the normal foot and in the clubfoot group were nearly similar. Whereas if you looked at comparing it with surgery, the outcomes were not the same. So what is the Ponseti technique? Why is it different? Where the hand position comes or where the finger is positioned. In terms of the manipulation, there is a fixed mechanism of correction. We may not go too much into details in this talk, but I will quickly summarize it in one of the coming slides. And it has to be followed exactly in that way. We use full leg casts as compared to the below knee casts in the other traditional plastering techniques. The cast with the knees in 90 degrees, so we have better cast retention. The mandatory tenotomy in almost 85 to 90% of these cases, and the bracing regime, the very, very most important part of it, which helped us maintain the correction after achieving a good correction, and the less frequent but longer follow-up. So all these is what resulted in the golden success of the Ponseti technique. And has this been validated? Yes, it has been validated by clinical studies, also by long-term follow-up studies. I showed you one of the landmark papers already on that. An average of 30-year follow-up, which is very, very difficult to achieve in our scenario generally. Plus, it's validated by objective scoring and MRI studies. So what is the Ponseti technique for those of you who are uninitiated or the postgraduates? If you really look at it, this is the complex clubfoot, or the complex anatomy of the clubfoot, the multi-segmented deformity. You start with a worsening cast of us just trying to align the forefoot and the midfoot together. You do nothing to the hind foot in the first few casts. Then you gradually bringing it into abduction without dorsiflexion, and you bring it out into full abduction. Only then you proceed with the tenotomy and then take the dorsiflexion. So like a spring gradually unfolds, the Ponseti technique slowly unfolds the whole foot, and you can see the beautiful clinical correction here. And how does it actually change the shape? So if you observe these bone models, by lifting the first ray, you are first aligning the entire forefoot together. Then you're gradually abducting the forefoot as one segment. Because you are now abducting the forefoot and the midfoot align up beautifully. And as a corollary beautifully, without touching the hind foot, when you're doing the forefoot manipulation, thanks to the ligaments which are interconnected, the hind foot, which is in varus, as you can see here, comes into the ankle mortise, comes into neutral, stays there. The talus starts moving in because now it is gradually being pushed in and it has more room to accommodate the talus. And then it comes into a full overcorrection there. And that's, if you've really learned how to do them well, this is how your cast should look at the end of the treatment. So quick clinical example to show you: a unilateral clubfoot, one of the first initial casts, then the cast which started abduction, the foot almost showing semblance of normal correction. You have to make sure that you have a perfectly straight lateral border. I will not talk about scores here because Tushar is going to cover it in his talk. Then we move on to the tenotomy, which is done slightly above the tendo-Achilles insertion into the muscle belly, ensuring 30 degrees dorsiflexion. That's a corrective cast, and that's the kind of great result you can have 2 to 3 years post-op if you maintain them well. And this is Pirani's beautiful study, which has shown that this is how the talus and the hind foot and the forefoot actually start moving into complete alignment, including reduction of the talonavicular joint. So when this was compared with traditional techniques, what was seen is that the need for further surgery was drastically reduced. And that is what we've actually witnessed as trainees ourselves in Vadia, where we used to do something like 12 to 14 PMRs a week sometimes. From that, the lists have become so thin or sparse in terms of PMR that I think postgraduates someday will have to really refer only to video techniques of PMR to really learn them. And there are numerous studies done, but Ponseti is clearly proven as the more effective, faster technique with lesser casts and better ankle movements and retaining the full suppleness of the foot. Again, this is a paper by Dobbs and Schoenecker showing excellent to very good outcomes in the Ponseti group and a lot of foot pain and stiffness in the, here they've compared to the PMR, but there are a lot of surgeries in which there was a huge shift in terms of bad outcomes to good outcomes. We must not forget in the Ponseti that the role of the FAB has equal contribution to the great success. And this is the classical FAB that they have used. In some cases, very syndromic ones where there are concomitant hip knee contractures, you have to move on to the AFO. But this is what really maintains and retains the correction, and therefore the brace rhythm and the way you wear the brace, parents have to be counseled really, really in detail. So moving on from the classical clubfoot to atypical clubfoot. In recent years, there's been a lot of talk about atypical clubfoot. Was it an entity that was really existing before? My submission is that I would think that this is largely due to a lot of the learning curve. In the master's hands, the techniques worked beautifully. But when a lot of people are adapting this technique and either using too much padding, principally not really using well molded casts, and allowing the foot to slip up inside the plaster, as you can see here, the foot deformity was therefore made worse because then it was subjected to abnormal pressures. So what was happening here is a deformation of already deformed clubfoot. How do you identify this typical clubfoot? You look at what is known as the plantaris, which is a deep transverse crease here and a huge high arch, as you can see out here, which is artificially created. This deep plantar crease usually extends right up to the lateral border. And along with that, a shortened, cocked up great toe, which was told to us in our PG days as a sign of poor prognosis. And surely that holds true for the atypical club feet. Because of poor casting, sometimes they have edema, they have a very rigid equinus because the heel gets completely squashed inside the plaster, as you can see here, when the child kicks, and the child is unable to really perform the movements. What happens in the cast is if you still go on, the abduction stops and you start getting a mid-foot break and you end up with a skew foot. So since the foot is not abducting through the subtalar joint, it is important to recognize this and stop the cast for a few days. And is there X-ray evidence? Yes, you can see here that in the plantaris compared to a normal foot, this is what is happening. The arch is getting completely deformed there at the midfoot level, and the entire forefoot is dropped down into an equinus. The same Siam image showing the same thing, comparing normal foot versus a atypical club foot, and CT images to show you how gross this deformation can be at times. So how do you tackle it? If it does happen, and it will in everybody's hands when you're learning the Ponseti technique, first leave the child cast without a cast for a few days till the great toe actually becomes longer and that flexion contracture improves. Let the edema settle, then start manipulating with the two thumb technique. This is how it should look at the end of 3 weeks of no casting. Focus only on the forefoot first, using both the thumbs and on both the first and the fifth raise. Correct the plantaris, dorsiflex the first and fifth metatarsal together, then gradually bring it into limited abduction. Do not try to attempt 70 degrees abduction like they do in the classical Ponseti. Go in for an early tenotomy, and once the deformity is corrected or braceable, you may require to have a modified FAB at times. However, in this child, we managed to get a full correction with the classical FAB. And the only modification we did here, we did not use extra rotation for the foot FAB. And that's the kind of result. So you can actually, with the Ponseti itself, with a little modification, you can restore even a complication which has been iatrogenically created. Along with that, there are some methods where you can use Ponseti technique even in the walking age children and even in non-idiopathic or syndromic club feet, as we have written these papers up from Wadia. So why did we decide to use that? A typical an atypical or a severe complex clubfoot that was thought earlier is marked by the following features. There's marked supination. The talus is extremely flexed and internally rotated, so which is much more worse a contracture than an idiopathic supple clubfoot. And there is very severe adduction and cavus. it's very, very resistant. The cast tends to fall off because you simply cannot, there's no space here. You cannot get your way in between. And there's a very marked equinus which does not allow retention of the cast. So what's the goal of treating this syndromic club feet? You need to make them plantigrade and braceable. And you will have to adapt your technique. How? This is how we do it. We do gradual abduction right from the first cast after aligning the first ray. We go in for an early tenotomy. We emphasize on dorsiflexion, and especially the casts are put greater than 90 degrees. In some of them, you have to counsel that there will be a longer program. An average clubfoot casting takes 5 to 7 casts, but here you may have to go up to 10 or 11 casts. And even after the tenotomy, early tenotomy, sometimes you have to continue casting. So there's a lot of counseling and detailed discussion which happens with the parents before we start that. Does it really serve to, is it a panacea? Does it completely cure the syndromic club feet? No, but it makes it much more braceable. It does have a higher relapse rate. It will certainly reduce the burden of the surgery in this syndromic club feet, especially when they have multiple things to deal with, hand contractures, knee contractures, hip contractures. So it definitely helps the child. And you may sometimes have to use AFOs or the FAB from an FAB shift to an AFO, and reduces the extent of a subsequent surgery in future. Some clinical examples, this was a child with a Freeman-Sheldon syndrome, very, very severe reduction, as you can see there. She responded very well to a few initial Ponseti castings, and then we did a minor open release, a limited posterior release, not just a tenotomy. And that's a 4-year follow-up. The child is doing extremely well. Here in MMC, they don't have the power to retain the correction because the peroneals are not working. Again, this was made a braceable clubfoot and a limited tenotomy was done there. And that child has done very well. Some more clinical examples are distal AMC, the ones who tend to respond the best, and those are long-term follow-ups. You can still see some residual forefoot adduction, which is then tackled with the AFOs. Can Ponseti be also used in the older child with clubfoot? Yes. What are the problems for them? There is an external rotation which cannot be given to 70 degrees because a neonate will tolerate 70 degrees abduction, but for the older child, it's very, very cumbersome. Hence, you accept an abduction of about 40 to 50 degrees. You tend to give them non-weight bearing synthetic casts, especially if it's bilateral, so that there's better retention of correction and they don't get osteoporotic because sometimes they require a longer duration. And also walking age children sometimes are very, very difficult to handle. So they may break your simple POP casts if you don't use synthetic casts in them. Adherence to brace program is usually a problem in these children. So therefore we use the FABs only at night, and in the daytime we switch to AFOs. Some examples again, an 8-year-old child, very severe clubfoot, literally walking on the medial side and on the talus. Post-treatment after 11 casts, done very well. And again, similarly, 11-year-old child treated with almost 15 casts, but again with a limited posterior release has done very well. So modifications to the Ponseti also are needed, and that can give good results. So am I saying that now we can treat everything just with the Ponseti? Well, not really. It's not gone completely out of the armamentarium. There are very limited indications for PMR in some syndromic associations where it is simply not possible to go ahead with multiple casts, or where the child is not responding to your plaster treatment. Or if there are economic and social concerns or concerns of migration, then you may use it. How is it done? Classically, this is a position of the PMR where you can see the entire deformity in front of your eyes. After taking the incision, that's the tibialis posterior, that's the tendoachilles, that's the FHL. All structures have to be identified after keeping the neurovascular out of harm's way. Open up both the joints, as you can see here, the subtalar as well as the ankle joint. Do a generous Z lengthening of the tendoachilles, and the talonavicular joint also needs to be opened up. And that's the kind of beautiful release you can get on table. Do not forget to do your abductor hallucis release and your plantar fasciotomy, and you can get excellent results. If the wound is a problem, you can use a rotation fasciocutaneous flap described by Dr. Rugis and Dr. Harold D'Souza from Vadia Children's many years back. Is all well with Ponseti as well, and we say that now PMR is out of the picture. Not always. If the rate of PMR went down, what changed the practice is that the rate of tibialis anterior transfers definitely went up. And this is because of the residual forefoot adduction, where you see that there's a very good correction of the forefoot varus and hindfoot equinus cavus. But on dorsiflexion, the tibialis anterior now doubles up as a supinator and tends to pull the foot inside. And therefore, because of this muscle imbalance, you tend to get a full recurrence. And that's an example of one of those children, if you can see the slow motion video well, that when the child is walking, especially in a unilateral clubfoot, it's very, very obvious and visible that he's landing entirely on the lateral border. And the tibialis anterior, instead of being a dorsiflexor, is just pulling the forefoot and midfoot into a supination and causing a great recurrence of the deformity. And in static pictures also, you can see the difference between the 2 feet. So what is done here then, if it's a supple foot, you will do a tibialis anterior transfer, and the rate of this surgery certainly has gone up in practice. In some rigid cases, especially if it's an AMC, you may have to add a decancellation of the cuboid or some osteotomies over there, and you can still get very good results with that. And finally, last but not the least, in our scenario, fixators are still pretty much in vogue for the very, very difficult, grossly syndromic, or the ones which are completely not amenable to either casting or your open surgeries, because they act like a joystick method which utilizes the principle of Ponseti and gives you excellent corrections, as you can see here. And this is very valuable even in the relapsed cases. This was a child treated with Ponseti, again treated with PMR, and yet she had recurred, and that's the kind of result that you will get. We will not go into details of these techniques here because the idea was to focus on how Ponseti really changed the practice of clubfoot. And that's the kind of result we got with the fixator and the surgery done. So in summary, what I would say is that what is also changing now is that a lot of club feet are being referred antenatally, but for lack of time, we will not go into those details. So learn the technique of manipulation correctly by watching again and again Ponseti videos, or by focusing on workshops which are held, and plaster it serially but correctly. Be gentle, do not be in a hurry. Assess objectively using the scores, which Tushar will talk about. Maintain a very close follow-up, because any good result can be ruined if it's not followed up well. And if there is a recurrence, you will have to reassess the child on individual merit, and then re-elect the method that you want, or what you know works best in your hands, especially for the untreated CTV. And in our scenario, I think fixators is a must-know if you really want to achieve a good result.
Thank you, madam, for the excellent summary of Ponseti treatment for the idiopathic, atypical, and syndromic feet. I now invite Dr. Agari Karujis to speak on harnessing the power of technology in enhancing clubfoot training and treatment.
Thanks, Ratna and Chasnal, for this invitation. And that was a great summary of where clubfoot treatment actually stands in 2022. I will submit here that since you're talking about what has been really practice changing in the treatment of clubfoot, it's not always that innovations in treatment are practice changing. I would say that one of the biggest disruptors, in fact, to the way we treat and manage clubfoot nowadays has been in how technology has impacted training and treatment. So in the next few slides, what I will try and show you is how we can harness the power of technology to train orthopedic surgeons, residents, and others in how to treat clubfoot, and also some other innovations in treatment using technology. So as we rightly said, the treatment of clubfoot over the last many centuries has been like a pendulum. It has swung between conservative and surgical methods, as has been well shown in the previous talk. And if you remember, almost 2,500 years ago, if you know history well, the treatment of clubfoot was in fact conservative, and Hippocrates famously used bandages wrapped in or dipped in egg white for serial manipulation and casting. We think that surgery is a new phenomenon, but actually in the 18th and 19th century, if you had a clubfoot or you have equinus deformity, the treatment was in fact surgical. And most famously, we know of William John Little, who had in fact CP equinus, who was treated with Achilles tenotomy by Stromeyer from Germany. Around the middle of the 19th century, we know that the plaster of Paris started getting identified. Guerin started using plaster of Paris bandages for treatment of clubfoot. Again, the pendulum around the middle of the 20th century, swung back again to surgeries. And Phelps, Brockman, and Steindler were the main advocates for surgical releases. As you can see, surgical releases became much more aggressive now in the form of posterior and medial releases, including bony surgery. Around the same time, as has been shown, Hiram Kite from the Texas Scottish Rite Hospital became a very leading advocate for conservative treatment. And many of you are aware of the Kite's technique of using sequential plaster wedging and casting to correct a clubfoot. Most of us who grew up around the 1970s and trained around the 1980s and 90s will remember that PMRs, popularized by Turco and Simmons, became the most popular method of treatment of clubfoot. And I remember that when we were in training, almost every clubfoot underwent a period of serial casting, but many of them failed because they didn't understand the actual principles of correction. And then most of them went ahead with a very aggressive posterior medial lateral release, as has been shown by the previous talk. And now we know that since the 1990s till date, it's the Ponseti method which has now become the treatment of choice for the management of all types of clubfoot, not only the ones who present at birth, but even in older children, in syndromic cases, in atypical club feet, as has been shown by Dr. Rujita. So we know now that the Ponseti method is the gold standard for the conservative treatment. It is, as we know, a specific method of manipulation and casting. It almost always includes a percutaneous stenotomy of the Achilles tendon. And there's a very specific method of bracing to look for long-term follow-ups. And many organizations around the world have endorsed the utility of this method. We were very early adopters of the Ponseti method in India, and we established our Ponseti Clubfoot Clinic way back in 2003. And then the next change that we underwent was in 2009 to then liaise with certain NGOs, as many of you all are aware, to set up a programmatic approach to treatment of clubfoot using the Ponseti method, where the NGO would provide us with free braces, help with the training of our residents, fellows, and younger orthopedic surgeons in the Ponseti method. And then over the course of many years, we have developed several training workshops and courses that I know many of you have attended. We realized immediately that there were very few training tools to actually describe and train people with the Ponseti method. So way back in 2005, we had the first training of trainers course in Delhi, where we established a standardized curriculum of lectures and hands-on workshops using foot models provided by MD Orthopaedics and various other groups to actually train many younger surgeons with this Ponseti method. There was very active mentoring by faculty. And even now, we conduct these courses. Of course, many of them have been hampered because of the COVID pandemic. We immediately realized that establishing a training curriculum so as to standardize the method of the Ponseti treatment was very essential for everyone. And certain global organizations led by the Global Clubfoot Initiative, which is located in Oxford, decided to establish a global clubfoot training. And we got several experts to come together. And I'm happy to say that we developed this curriculum of the Ponseti method, very carefully describing the method of manipulation and casting, the role of tenotomy, the abnormal anatomy and the pathology of clubfoot, and various resources available to people, especially in low middle income countries, of how to adopt this method so as to look at a good long-term outcome of these children. The next eventual step, obviously, after developing a curriculum, is to use technology to advance the rapid uptake of this training. And we liaised with Orthopaedics, which is a Boston-based company, and established an e-learning course. And many of these tools are available on the Global Clubfoot Initiative website. They're available in Global Health as well. And for anyone who's interested, these are available as free downloads, where you can look at the anatomy, the pathology of clubfoot, look at the various treatment modalities for clubfoot on this website as well. We also then established a liaison with developing animations, and this was with a Spanish company where we developed the world's first animated 3D model of clubfoot. We realized that many people, especially during the COVID pandemic, are unable to attend physical courses. And what we did then was to establish this kind of an animation where you can see that the Ponseti method can be broken down by using these very skillful animations, showing us not only the anatomy and the pathology of clubfoot, but where you can actually practice the various handholds, showing how to do the correction, going sequentially from correction of cavus, adductus, varus, and equinus, including a short video on the relevant anatomy during anaculus tenotomy and the actual surgical technique for doing a tenotomy. So here I can see that technology has had a very strong role to play in helping people train with the Ponseti method, so that in these difficult times where it's impossible to travel and to actually attend a physical course, you could use these e-learning and online tools to improve your training and treatment skills. The next thing we realized is that bracing is an important part of the Ponseti method, and that really was the Achilles heel in a way for the treatment of clubfoot. And there were very little ways to measure compliance of the parents towards bracing. We found that using parent-reported criteria are not reliable at all. And we decided to see whether it's possible to integrate sensors into the braces so that we could actually establish that the parents were being adherent to the brace wear. And this was a 2-year project which won us the SICOT Research Academy grant, where we liaised with the Indian Academy, the Indian Institute of Technology in Powai, to look into the development of a functional prototype of what we call a smart brace, which basically stands for a sensor integrated to monitor and remotely track the actual hours of brace wear that the parents were using. So this, as you can see, was a tripartite arrangement between the Indian Institute of Technology, an international NGO, which was helping us with this project, and our hospital, to establish at least a prototype to see whether it's feasible to develop this kind of technology for clubfoot braces. So we went through various iterations of looking at types of sensors, going from pressure sensors to touch sensors, understanding that the requirements of the sensor technology is that it should be compact, it should be reliable, more importantly, it should be low cost and use easily available technology, which can be easily adopted in low middle income countries. We finally honed on the fact that we need to develop 2 types of sensors. We need to have one type where it actually proves that the foot is lying within the shoe. And the second type is that the shoe is actually logged on or to the brace. And we use 2 sensors, which is, one is an infrared sensor, which detects whether the foot is latched into the shoe, and a magnetic Hall effect sensor to detect whether the shoe is then latched onto the bar. And this was what we developed, essentially, a modular attachment which contained all the various electronic devices, which was fitted onto a particular type of brace. But there's no reason why this technology cannot be adapted to any other type of foot abduction brace that are being used in low middle income countries. So to give you an idea of the wireless technology, what we established is that this prototype, the sensor data could be picked up. There could be a local storage into a chip which is there within the brace itself. And then using a mobile app interface and Bluetooth technology, we could transmit that data to a cloud storage, which would be immediately available to any physician who's sitting in the clinic to analyze that data in real time. So you don't have to wait for the parents to come back for follow-up visits every 3 to 6 months, but on a daily basis, the doctor or the clubfoot specialist sitting in the clinic can actually analyze whether the child is wearing the brace at a given time on that day. Just to show you the various aspects of that technology, I don't want to go into the details of this, but this shows basically the circuit board, which has the infrared sensor, the memory card to log the data, and the Bluetooth low energy module, which would transmit the data from the brace to the mobile app. We also developed, obviously, the mobile app and a web app so that every parent could download that data onto the phone and then transmit it using the technology onto the cloud server. We haven't started the clinical trials yet due to the COVID pandemic, but the initial prototype, we had a 3D printed foot to actually show whether this technology works. And we tried various permutations and combinations where we tried using the foot inside the shoe without clipping the shoe onto the bar, not putting the shoe on, not putting the foot inside the shoe, but only having the shoe clipped onto the bar. And we were able to track that we were getting reliable data from this assembly, which could be transmitted remotely via the mobile app and the web-based server. So this really shows us that it is feasible to incorporate these low-cost sensor technology into the clubfoot braces. So you not only have local data available to you on a chip within the brace itself, but even use wireless technology, which is really cheap nowadays, to transmit this braceware data remotely to a clinical administrator or a healthcare provider sitting in the clinic. Hopefully, this will cause parents to become more inclined to adhere to the recommended braceware, because now they are aware that the healthcare provider can access their daily braceware usage on a real-time basis. And we have shown that this prototype can really be manufactured cheaply and can be easily accessible in low middle income countries. So this is really one new advance that has come out in the use of braces. And we hope that over the next couple of years, we can move on to clinical trials, which will actually prove that this technology does work. Finally, I would say that technology does not always have to be extremely advanced to be adopted. What we realized during the COVID pandemic is that the biggest hit that we took was on clubfoot casting, because while we know that clubfoot treatment is time sensitive, it is not really an emergency procedure. So during the 3 months of lockdown, clubfoot services ground to a halt. And then when we restarted our clinics, we realized that parents were skeptical in returning back for clubfoot treatment. And we were seeing many children who were coming back to us with untreated or neglected clubfoot. And so we thought, is there a method that we could use to safeguard ourselves and our parents from the risk of disease transmission? And we came up with this very simple technique, which is called ring fence casting. And we published this subsequently. What it basically means is to create an impermeable barrier between the doctor who's providing the casting and the patient who's on the other side of this membrane. And you can see what we have used is a simple plastic drape, which hardly costs 100 rupees. Cut out 2 little holes where the feet can be put in through. So you have the parent and the child on one side of the drape, and you have the person who's applying the cast on the opposite side, hopefully keeping them safe from aerosol transmission. So this is to show you, one of my fellows took a very keen interest in this project, and we developed this entire technique and then published it in the Indian Journal of Orthopaedics. I would say that this is a very simple method to protect ourselves during this pandemic time. And we know that this is a disease which is going to be endemic for many years to come. And I would urge many of you to adopt this technique, not just for clubfoot casting, but anywhere in the clinic where we are exposing ourselves to a risk of disease transmission. So this is in short the technique that we developed. We have, for those who are interested, this is the link to the article. And therefore, in conclusion, I would say that several advances have changed the way we treat clubfoot over the last many years, not only in the respect of the medical management, but also in the way technology has impacted us, both in training and in treatment. Thank you very much for your attention.
Thank you, sir. That was an excellent, excellent talk. And thank you for making us aware of the global club training curriculum, the e-learning tools, the 3D animations, the smart brace, etc. Thank you very much. I now invite Dr. Tushar Agarwal to speak on assessment of outcomes in clubfoot.
I'm visible and audible, right?
Yes, sir.
Yeah. Okay, great. So as we keep treating these clubfoot patients, we feel that they are getting corrected. But do we objectively sort of document that they are getting corrected? So let's see that by our outcome evaluation talk. So Simon Sinek is a very great author, and he became very popular when he started talking about start with a why. So for any activity, you have to be very clear as to why you're doing it. So why am I doing this outcome evaluation of my clubfoot? So there are 3 points here. I want to know, is my patient doing well? Am I able to pick up something early enough to avoid a future surgical intervention? And can I assure my patient's parent that now he or she can be free from all tensions of this clubfoot and stop following up with us? That's a very real question which they have to answer. Now, are there tools like this departmental store picture, which are available to me to achieve these objectives? Are they easy or difficult to use? And are they foolproof? So what happens in the CTEV journey? What really happens is that if the parents were told of all the difficulties that they are going to face at the outset of this long journey, most would not start out at all. So we are not going to inform them of everything right in the beginning. And of course, at the outset, the deformity is very ghastly. And at the end of tenotomy, virtually all are doing brilliantly. There are some parents who have issues with bracing and compliance. Also, there are outliers who might have issues in spite of excellent bracing and compliance. So we see the journey. This is a unilateral clubfoot, this is a bilateral clubfoot, looks so ghastly to the parents when the child is born. Immediately after our process of Ponseti casting and tenotomy, they look brilliant. Parents are very happy and satisfied. As they keep following up with you regularly with proper bracing, the feet look really great. Most of them we manage with alternative bracing also if they don't adapt to the standard Steenbeck bracing. And they look really great just about when they come to walking age, and you have smiling and happy parents. But what happens then is that some of them become a little lax about follow-up. Some of them may return to from where they have come. And then they may have such kind of outcomes whereby they start walking on the lateral border. They may have active supination of the forefoot. They may have cavus of the forefoot. Problems with the hindfoot and midfoot both. This is a patient who came to us, who was totally okay. And, suddenly they surface at 10 and 11 years of age with certain problems. He's now unable to squat comfortably, sit on the floor, and some degree of oddness the parents seem to notice in their gait. So this patient has directly surfaced after 11 years. Both these patients have been treated by me from the early neonatal age group. We have followed them thoroughly, and eventually they've got lost to follow up at some point of time. So they may have static findings of restricted dorsiflexions, which we have to document. Now, this is the story of a clubfoot which has gone so bad. At a distant place somewhere else in India, he received the standard Ponseti treatment, and then they came to us, we treated them, then they've got relapses on both the feet, and one feet is doing really bad. So this is like a really poor outcome. And not to get disheartened, this is like a 16-year outcome of a child who was treated with Ponseti, and she looks so wonderful. She actually came as an accompanying relative to another patient. So how do we sort of classify our outcomes? Is it enough to call them the good, the bad, and the ugly? Or more details are needed to document them in order for us to make a smart decision about further management? So to answer that question, we'll analyze two articles, the 2020 BJO article by the lead author Deborah Eastwood. And what does this article say? So they analyzed the outcome evaluation scores coming from all over the world, submitted by all forms of practicing Ponseti practitioners. All the patients included in this article were patients who underwent only Ponseti treatment and no other form of clubfoot treatment. And roughly 20 points have been considered when we are following up those patients, namely like the heel position, the forefoot position, the footwear, foot size, etc., etc. Right? And then in their article, they analyzed each and every score that was available to them. These are the scores which were there in early 80s and 90s. As Dr. Rujuta wished me to include, the Pirani score is a part of this article. However, it is not really like an outcome evaluation score after finishing the treatment, but it is an outcome evaluation score during the process of treatment. Most of us are very familiar with this score as we use it for our regular treatment. Now, there were so many more scores which were available. And I was most impressed in my review of this article by the Bangla Clubfoot Tool Assessment, which we'll see in detail later. So there are numerous scores which came, and in this article, what they analyzed is at what point were these scores applied and what were the inter and intra observer consistency in utilizing these scores, and how many more studies were there which utilize this particular score in their studies. So there was some consensus. What they are saying is that the outcome evaluation scores are mainly designed for ambulatory children, so namely after 18 months to 2 years. The main component is the parent reported outcome measures, that is on topics of pain, shoe wear, play, school issues, and emotional impact. The clinical outcomes were documented in the form of yes and no. There were quantitative outcomes in the scores, and there were a combination of qualitative and quantitative outcome in some scores. Some scores involved gait in the form of running, squatting, observational gait analysis, and instrumental gait analysis. All, however, wanted to explain the concept of a failing foot, but were we successful by any of these tools? So they sort of concluded at the end of their article is that we are yet away from the ideal tool, which should be an easy to use, comprehensive tool. It should be adaptable to local resource. So it should be the same in New York, San Francisco, as well as in some deep territories of Congo, right? And it should be tailored to geographical area. It should involve the static evaluation of the patient, the dynamic evaluation of the patient, and also the parent reported outcome measures. Plus, it should be validated and repeatable. So all this became a tall order, and it was concluded that yet such a tool is not available to us. Dr. Alrich is a part of this great article, which was published in Journal of Foot and Ankle Surgery, the Asian edition in 2021. And they again evaluated each and every score available to them. In this, they mentioned mainly in their tables the scoring scale and whether these tools were validated and in what environment were they validated. Okay, so again, they mentioned each and every tool. Now, after reviewing both these articles, I must say the Bangla Clubfoot tool, which has come in 2014, is a very interesting tool. It has 11 sort of maximum points available, 1 to each question, and there is an impact of negative marking. And the main point here is that they ask the parents, they assess the child dynamically, and they assess the child statically. And because of the negative marking, it has sort of a very validated feel to it. Also, it has been validated and reproduced and used in at least 4 studies after it was evolved. Now, this is one of the simplest score if you want to use. It's called the ACT score, the Assessing Clubfoot Treatment Tool. And it involves only 3 questions to be answered by the parents. That does your child complain of pain in the affected foot? Can your child wear the shoes of their choice? And how satisfied are you with your child's foot? And one question is to be answered by the treating physician, is that the foot, whether it is in the plantigrade position or not. So this, to my mind, is the simplest tool available. The Lavek-Ponseti tool was one of the first tools which were put into practice. However, patients would get very high scores because they gave very high prominence to pain, which I feel in our practice, patients don't really of clubfoot complain of pain, at least till the point we follow them up. Now, this is the International Clubfoot score. This is a very, very detailed score, but as both these articles, which I just showed their review, pointed out that the more detailed the score, the more difficult it is to use. And outside of the main group of authors who use this score was never again used because of the difficulty in using and applying it. The proponents of the score said that the score is very objective and it's very easy to enter into a computer and then do the final data analysis. Now, like they showed gait analysis in cerebral palsy, is there a role for gait analysis in club feet? So for difficult redo surgeries, yes, there is a definite role. So this is a patient who had a very good endpoint of treatment, however, kept walking with an in-toe gait pattern. On my first assessment, I did a tibialis anterior transfer on the right side. And yet, after a while, I didn't notice a very, very good outcome. And in fact, the left side was good in the beginning, but it started deteriorating. So what the graphs are telling us that there is a limited dorsiflexion, the foot remains in equinus, and actually the culprit muscle is tibialis posterior. So probably in this patient, we had to do a double transfer, a tibialis anterior and tibialis posterior transfer, which is a rarer surgery to do, which was brought about by gait analysis. However, I must point out that gait analysis is never going to become a part of a generalized clubfoot outcome score. So now from this article, which was brought out by Dr. Alaric as a co-author, it said that all future scores have to be a composite measure. It has to take care of the structure of the foot and the function of the foot. It has to be ultimately be translatable into the local language in the country in which we are practicing. It has to have a cross-cultural validation. So if it is invented by a Britisher, it should be validated by an African as well. Squatting and hilly areas climbing should be a must part of any future scores which are developed. And the score should be applicable in both the developed and the underdeveloped world. This is a sentence picked up from the article that this can be achieved through a multidisciplinary working group, which will include healthcare providers from both economically developed and underdeveloped regions, social scientists and experts in the design of testing and outcome measures. Now, very interesting take on this Clubfoot outcome was that they took a set of Clubfoot treatment providers in 2017 in January. This article came in 2017. So they took them across 2 time zones in Jan and after 6 months, and they found that actually speaking, in spite of talking so much about Clubfoot outcome scores, it's only 4 criteria which ultimately matter or which is given maximum emphasis. Is that a simple physical assessment of foot, the footwear use, the patient pain, and the parent reported outcome measures. So only 4 points are very important. So with that, we have innovated a small sort of Clubfoot outcome score of our own, which resembles like this, and we try to apply it to our patients. This is one of our patients who came, who's at 4.5 years, unable to squat comfortably, and parent is reasonably happy and satisfied. There's no problem. They are very, very compliant with bracing. However, when we do our static eval, we did find that dorsiflexion is coming to neutral or just about 10 degrees of static dorsiflexion. There's no static forefoot adduction. And yet on our score, the patient would come as a fair outcome. However, in our score, we did mention 2 red flags. And the red flags are that if they score 0 on any one particular score, then it's a big red flag. Or if they go below 3 on 6, then it's a very big red flag. So here we find that there's no 0 on any score and they're not going below 3. So we can just continue with our current treatment. A scoring, what I'm trying to say is don't adopt this scoring, but adopt some form of scoring to objectivize your counseling for your patients. Now showing a series of fair outcomes. However, I must say that there was this article which has just recently been published in 2021. And they say, irrespective of whether it's a male child or a female child, whether you have a unilateral or a bilateral clubfoot, all perform equally well, at least at recreational sports. And this article says that the total participation of sports is almost more than standard kids of the same age, those without club feet. So what do we conclude? What I conclude from the review of literature is that as yet, we do not have a totally ideal tool. 4 points are very important. Please note this: pain in the feet, wearing of shoes, appearance of the foot as per the parent or the patient when he grows up, and the presence of a plantigrade foot. Now, scientifically, the score should be validated, reproducible. It should be utilizable across geography and cultures. There was a very important question which was asked to me when I was preparing this talk. Can we predict at the outset of treatment, when we are giving the Pirani score, which foot is not going to do well? Well, there were no articles to validate this. So honestly, all patients with a Pirani 6 almost become like a Pirani 0.5, Pirani 1. But whether they will do well in the later outcome depends upon our tight follow-up of these patients. Hence the importance of outcome evaluation tool. Thanks a lot.
Thank you, sir, for that comprehensive overview, and yet giving us 4 important points to take home. So we have some time for questions. There was one question in the chat which was on closed needling, I think for the TA tenotomy. If Rujuta madam can take that.
Yes. So what was the question? Do they want to know whether it's recommended or not recommended?
Your opinion on closed needling.
Oh, so I think let's put it this way, that there are many ways to, do the same. What works in your hands. If you've got a perfectly straight lateral border, if you do it, whether you use a 15 number knife or whether you use it with a needle, or use a 16 or an 18 gauge needle, which is actually as thick as the beveled edges, and it should be sharp, as good as the 15 number blade. If you really precisely do it where it is described and you are sufficiently trained in it, you make sure that there are no residual tethers remaining there by putting a small little artery, which is that I've picked up from Alric over the years. Make sure that there's absolutely no tether holding it back, and see to it that you get a 30 degrees dorsiflexion. Then usually it works just as well. But you should really know there have been incidences of where to put that needle. So because it's a blind technique, so there have been incidences of extra bleeding because you've cut the saphenous by mistake and neurovascular damage. So it's not to be taken lightly, but well done in the correct hands can get you equally good results.
Okay. And there was another question. At what point do you give up on Ponseti, say for a syndromic foot? Is there an objective tip you can give to people listening?
I think if you're not able to align your forefoot to the midfoot at all, I think that's point number one, where it shows you that this is very grossly rigid. But I think 95% of your syndromic feet won't really show you that. That's only going to be a very one-off, very, very rigid foot. Then if you really use the technique in the absolutely correct way, and if you're simply not able to go beyond even 30 degrees of abduction, then that, to my mind, something which is moving from neutral to 30 degrees with great difficulty is a definite indication of severity. And it's been well described. Some of these feet, especially when you encounter these kind of problems, you should think of tarsal coalition. It's rare, but in syndromic cases, it's known, especially the ones that are associated with maybe some of the hemimalias or things like that. There, no matter what you do, you won't get it. So then it's better to leave the foot alone for some time and then fall back onto your traditional techniques.
Okay. There's a question. Has anyone had a need to do bleeding and clotting profile, I think, before tenotomy?
So I think routinely, surgically, we used to do that when we were doing major surgeries, but not really. Most of these Clubfoot programs actually do these surgeries. I mean, tenotomies even in the clinic as an OPD procedure. So yeah, word of caution surely there. In the one-off patient, it can happen, but we don't really do it routinely. Alaric, your views on it?
I would agree. This is a sort of minor procedure, even for major surgeries now. I don't think we are doing bleeding clotting profiles for anyone. So it's so uncommon and so rare that it's not really recommended. It's an outpatient procedure. I don't think it needs any elaborate investigations to be done. It's done on local anesthesia as far as possible.
So if you can tell our trainees here, how do they access the global Clubfoot training curriculum, the animations, etc.?
So some of it is still in the terminal stages of development, but a lot of training modules are available on the Global Clubfoot Initiative website. So if you're interested in the link, it's globalclubfoot.com. And if you go on the website, there are not only resources for training, but also information about various webinars that are held very regularly. In fact, we recently had one on the walking age of the older child, which was very well attended, because there's a lot of controversies about the role of the Ponseti method or the Ponseti principles in this older age group. And there are some deviations from the standard Ponseti protocol that we use in younger children, then we use it for the older ones. So you'll have exposure to repeated number of webinars that are available. There are various publications which are collated from around the world and put up on the website. I think it's a good place to, as a one-stop shop for various resources on Clubfoot treatment, especially with respect to the Ponseti method.
We have no other questions.
So I wanted to ask Tushar something. So you elucidated a lot of the scores for us. What do you think is the single most point which actually determines outcome from the patient point of view, not from our point of view? Is there a single most point at all, or is there, I mean, you would want to give us 2 or 3 key points?
So what came out of the literature is that there are 3 points from the parent's perspective. Is that, is the child able, are they happy with the form and function of the foot? Is the child able to wear the shoe of his choice? And does he have pain in any of his regular sports or recreational activity? So these are the 3 points. And from our point, there's only 1 point, is that the foot should be plantigrade. The emphasis on squatting and walking on hilly areas is coming more from our geographical territories. I don't think it functions so much in the Western world.
So would it be okay to say that as a corollary, getting a good dorsiflexion and maintaining the good dorsiflexion is actually the, one of the key indicators to look at?
From my experience, I feel dorsiflexion is always a challenge in clubfoot, and we may not be able to get the dorsiflexion which is required, or which we really envisage in each and every foot. So probably some degree of dorsiflexion, even if it's 10 and 15 degrees with the knee extension, that is what we envisage, should be more than enough. I don't think eventually we get full dorsiflexion, but I endorse the view that we have to really work hard at getting the dorsiflexion.
Unmute, ma'am. Tushar sir, will the parent objective or the parent perception change for a unilateral or a bilateral? Because the unilateral club feet, the kids, they have some discrepancy in terms of the muscle girth, the leg.
From whatever I, sorry to break you, but I'm supposed to answer that. So from whatever I understood, I really didn't think that this was brought about by any of the articles. I may have missed it. Yes, but in our practice, definitely, if it's a unilateral club foot, they are quite harassed with the calf atrophy. But I think, like I mentioned in my talk, the initial appearance of the foot is so ghastly that I personally feel that 99% of them are pretty happy with the outcome.
Well, good. So,
Madam, you're on mute.
Ma'am, unmute, ma'am. Ma'am.
You just make a point, Tushar.
Yeah, Atul.
So I think what Alric and what the papers have shown that
I am unmuted on the phone. Can't hear me?
Early on when we were
proposing. Any more questions?
Atul is making a comment.
Any more questions for us?
Ma'am, Atul sir is having a comment.
Yeah, sure.
So I think one of the things was really about this lack of squatting early on. And I think that is one of the key signs to pick up. And I think in their follow-up, you find that they're getting difficulty in squatting. And most of the children can squat by 2 or 3 years. But when you find that decreasing, I think that should be picked up very early, and especially in our scenario. And the other thing is the bracing compliance, which we had shown. If you wear the brace less than 8 hours, you almost get 100% relapse. I think the timing of bracing, again, it becomes important. So, when you're using these smart devices, it's worth documenting at what level, what is the critical point where the bracing will impact your relapse. So I think that is where challenges lie in terms of duration of brace wear. Thank you.
Alric sir, we usually recommend bracing till age 4. And we see recurrences or dynamic supination or slight forefoot adduction in older kids like age 10, 12. So in them, should we recommend some splints or just go for some intervention or recasting, or what should be done? Like some walking splints or shoe modifications?
Yeah, thanks, Shasta. I think that's a very interesting question. It's very interesting to know that when we look at relapses and recurrences, use of brace wear, there is no hardcore evidence really. A lot of it is so arbitrary. A lot of it has just come from Ponseti's thoughts, and there's been really no proof as to how long we need to use the braces and for how many years, There's a school of thought which says now that maybe even 8 hours of brace wear for 2 years might be sufficient. And again, we don't know whether that's true or not. And a main reason for this is we realize that we don't know anything about the adherence to bracing. You know, what we recommend is one thing, but what the parents actually do is another thing. And that's really what stimulated us to think about using sensors within braces so that there's a more objective way now of actually documenting what compliance is. Because so many studies which have said, 2 years may be sufficient, or brace till the age of 4 or 5 years is required, are all based on patient or parent reported adherence, which we know is extremely unreliable, especially in a situation like ours in low middle income countries, where parents are not very forthcoming with what they're really doing. They very often want to please the doctor. And when we have this paternalistic attitude that we impose certain things upon parents and say, you have to do it, when they come back, they want to say that, oh, yes, of course, we did follow your orders. Unlike, in more developed countries where patients and parents are more honest with what they're actually doing. So I think the jury is still out about all of this. I think what we should do is treat each case on each patient on a case-to-case basis. If you are seeing a relapse coming in, I think you must return back to the use of foot abduction braces. At least has been shown that the unilateral braces by themselves don't really act well, especially with an AFO. But there has been some recent advances in what's called the ADM brace, which is available in some developed countries. The cost is prohibitive abroad. We're trying to see whether we can get that technology down to India at a much lower cost. But that's the only unilateral brace probably which has been shown in some studies to work in children with a recurrence. But I think if you see on a case-to-case basis that there is early recurrence coming in, reinforce the use of the foot abduction brace even at an older age, because I don't think age really is a protection against development of a recurrence. As you rightly said, most recurrences occur within the first year after treatment. There's the very high risk in the first 4 to 5 years, but we have seen children even after the age of 5 who come back with a recurrence. So I don't think there's anything written in stone. We must be flexible as clinicians that if we see a recurrence coming in, to reinforce the use of a foot abduction brace and go back again to treating that before there's a full-blown recurrence.
Yeah, thank you, sir.
Tushar wants to say something still. Unmute yourself, Tushar.
So taking off from where Professor Alaric just ended, I feel in we had this small cohort we studied, and we found that after the completion of Ponseti, the patients and the parents start following up. We also very eagerly follow up all the patients, and somewhere around 18 months of age, they're doing so well that we may get little complacent and say, "Acha, abhi aap 3 mahine ke baad aayiye." And that is the time between 18 months to 24 months. I found that the first evidence of relapses start occurring in a well-positioned foot. So if I may just guard people on slacking their follow-up, in fact, now I have started saying at the onset that between 18 to 24 months, you start following up even more tightly, more regularly in order to pick up. And one more comment on Atul with restricted dorsiflexion. I sometimes feel that we may have restricted dorsiflexion, but if you take a lateral X-ray, there's no real equinus seen in the hind foot. So I don't know whether there's any role for tenotomy or posterior capsular releases at that point of time. And actually, the equinus is probably coming more from the midfoot rather than the hind foot.
So if there's no more questions, then I think we're almost nearing the end of our scheduled time for the Master Series. I would definitely want to thank both the Girl Power conveners for really putting in heart and soul into crafting this program, really touching upon all the important areas where significant changes have taken place and shifts have taken place in practice. I want to thank all the faculty, that is especially Prasad, for staying up so late, although he's across the 7 seas. Mandar, Sandeep for, despite their ill health, really tuning in and doing such a fabulous job. Taral also, who's, handling multiple things, and yet he's just delivered such a paisa vasool talk. My dear friend Vinoti, Atul, and Tushar for absolutely on point lectures, and Alaric, of course, for his usual professorial famous last words kind of lectures. And Swapnil for a beautifully illustrated and very well covered exhaustive topic in a limited time. Our webmasters for silently and strongly supporting us. And most of all the audience who has tuned in. And here's on behalf of Bombay Orthopaedic Society, wishing you a very, very safe 2022. Let's hope we've already started seeing the beginning of the end. And don't forget to tune in on Friday for the BOS Day. It's first time that we're celebrating it virtually. And it's going to be a very, very special program. Right from Dr. Lad to Ranveer Singh, we have a good power pack